While we meet on a virtual platform from coast to coast to coast, we acknowledge the ancestral and unceded territories of all the First Nations, Inuit, and Métis peoples that call these lands home. We affirm our commitment and responsibility to improving our own understanding of our local Indigenous peoples, including First Nations, Inuit, and Métis, and to improving relationships. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past that continue, and to consider how we can each, in our own ways, move forward with meaningful efforts of reconciliation. Last year, I opened by remarking that the issues of the sustainability and effectiveness of healthcare systems and delivery have been never more in the forefront of people's minds than they are today. That never before have patients felt more that they need and are entitled to a meaningful voice in the future upon which their welfare depends. These words are just as true in 2023. The economic and political worlds in which we find ourselves can be frightening, filled with serious concerns for the present and uncertainty for the future. Health systems and policies are high on everyone's agenda, but there is no such thing as a homogeneous patient, as you will hear throughout the summit. We would like to thank our sponsors, Janssen, Merck, Pfizer, Roche, Amgen, Bristol Myers Squibb, AstraZeneca, AbbVie, and GSK, for making it possible for us to come together virtually to share experiences, to learn from our speakers and each other, to determine our roles in this shifting landscape and how to move forward. Thank you to Innovative Medicines Canada for funding the summit working groups that support our work throughout the year. Over to you, Sharon.
Sorry, I'm the first one to do it. Okay, so this summit has recognized the need for real change. And in previous years, we have worked together to determine how this should be achieved for the benefit of patients. We concluded that a value-based system resting on a foundation of patient-supported outcomes and pan-Canadian data management will lead to integrated models of care and systems changes that ensure that each patient population in our society, no matter where they live or their income, receives the healthcare they need. In order to start along that journey, we must meet people where they're at. The strategies to develop and maintain equitable, equal, sustainable, and transparent health systems will be different for different populations. We are not starting at the same starting line. So how do we ensure that health systems and other systems impacting the health of each patient population learn how to listen to and learn from those who have often been left out of proper planning and implementation for our health systems? Perhaps most importantly, how do we bring together federal and provincial, territorial decision makers to collaborate and to bring in other healthcare stakeholders, including patient populations, to solve these problems? We can only answer these questions and the answers to them by understanding from where each of us is coming from and what we require from our healthcare systems to meet us where we are at. Over the course of this summit, you will hear from an array of amazing, courageous, tireless speakers with lived experience of the relationship between lack of access to social determinants of health and health outcomes, as well as the caregivers, support systems, healthcare providers, government representatives, and other partners, both Indigenous and non-Indigenous, that help them to make their voices heard. Then we will meet them where they are at and rebuild health systems that include them. So thank you all for attending, and best wishes, and enjoy the summit. Thank you.
Thank you for the welcome, Kathy and Sharon. And I'm just going to briefly, my name is Leah. I'm just going to briefly take us through a little bit of introduction and housekeeping. So just a reminder that this is a multiple day summit. Today, we are very excited. Our theme that we're going to be diving into are challenges to meeting people where they're at. And we have an incredible lineup of honor to have an incredible lineup of speakers to follow. On Wednesday, we hope you'll join us for our next day, which is themed Highlighting Indigenous Health Needs. And on Thursday, we move towards a more of a deep dive on some foundational solutions and shifts that need to happen, those opportunities to modernize healthcare to meet the needs of all. And for all of our patients and caregivers and patient and caregiver groups, you are welcome to join our patient planning session shorter on Friday. So today we have this incredible lineup, and we will be moving into our keynote very soon, and then a couple of different panels. Our first on intersecting oppressions, and then two social determinants of health that we'll be exploring a little more deeply: housing insecurity and income insecurity. We will have breakout sessions at two different points today because it is a lot of content, and we want to help facilitate the ability to digest and reflect on what you're learning at a couple of different points. So these are important sessions. We really do hope that you will stay and participate in the small group discussions. It takes many incredible people and organizations to pull off an event like this. And so I want to start by thanking the two patient organizations who are the partners that make this all possible: Save Your Skin Foundation and the Canadian Psoriasis Network. And thank you again to all of our sponsors. Kathy named them by name. Here they are. And none of this would be possible without you. So please accept our deepest thanks. Thank you to the Summit Organizing Committee members: Sharon Clark, Louise Binder, Antonella Scali, Chantel Burrows, Kathy Bernard, Taylor Tomko, Sylvia Larico, and I'll pat myself on the back. And thank you to all of the members of our working groups, particularly Health Data and Integrated Models of Care, for your participation throughout the year, moving some of those foundational reforms forward. Thank you to our French interpreters, Ciro and Oksana, and to our French translator, Rochelle Fecteau from Traduction Rhizome. Big thanks to our technical support, Lance Lee, and thank you to all of our volunteers who are facilitating breakout groups during the 3 days: Ursula, Lori, Megan, Cheryl Ann, Nathaniel, Nancy, Christine, Taylor, and Iman. It's really important, those breakouts, and we do deeply appreciate your volunteering, your time and effort. So some quick housekeeping. During plenary, all lines will be muted automatically and videos will be kept off. We are recording the session in English and French as we do share out these summit days through YouTube so people can enjoy and benefit from the content if they're not able to be here live. If you need French interpretation, then please click on the world icon at the bottom of your screen. You can click mute original audio and then select French. And please note that French interpretation will not be available when we screen videos and in our breakout sessions. So if you need assistance with French during the videos or during the breakout sessions, you can click on the closed caption icon. Next to the show captions button, you click the up carré button, the circumflex, and then under translate in the menu, you click on the language you want the captions to translate to. So if it's French, you would select French. During the breakouts, you can unmute yourself and participate in the discussions. Those of you who did indicate that you need assistance with French, we have placed you in a breakout room with a facilitator who is bilingual, so some assistance is available there. You can also use captioning if needed, as mentioned. If you have, we hope you have questions, and we encourage you to use the chat at the bottom of the screen to share your questions with us. Press enter, and then during the moderated Q&A, we will be happy to bring your questions forward to the speakers. And if you have any technical difficulties at any point during the summit, please contact Lance Lee through the chat function. Please share the ideas that are inspiring you via social media, your various social media accounts. Use one of these hashtags to let people know that you are part of this conversation online. And just a reminder that we will be sending out very brief evaluation surveys after each day of the summit. They're really important to learn how we're doing and how we can improve. And there will be an event report in both English and French that will be prepared by the end of the year and shared out with all participants through MailChimp, through our web, and also through our webpage at Save Your Skin Foundation. Now, I'm very pleased to introduce Louise Binder, Health Policy Consultant at Save Your Skin Foundation, to introduce today's keynote speaker. Over to you, Louise.
Hello, I hope you can see me and hear me. I'd like to welcome all of you from wherever you're joining us and whichever time zone you're joining us from. And I'd like to start also by acknowledging that in Aurora, where I am, we're on the traditional and treaty territory of the Chippewas of Georgina Island, who are Anishinaabe peoples and one of the First Nations reserves in Ontario. We're grateful to them for sharing their lands with us. I first met Dr. Naheed Dosani when he spoke at a panel for CanAge, an amazing organization advocating for seniors. He was speaking on health equity for aging populations. I had been actually following him on Twitter, aka X, for some time, so I was thrilled to meet my favorite social media star. The moment he jumped off the stage, I introduced myself and asked him if he would speak at the Patients Summit this year. He immediately said yes, and he said it so quickly that I thought he was probably just trying to get rid of me as quickly as possible. However, on the contrary, he responded to my email invitation in no time at all. Dr. Naheed Dosani is a true health justice activist. He's a palliative care physician who, among other things, started the Palliative Education and Care for the Homeless program, also called PEACH, in downtown Toronto, as part of his efforts to advancing equitable access to healthcare for people, including those experiencing structural vulnerabilities such as poverty and homelessness. He has been recognized for his trailblazing work by numerous governments and associations. In the next few minutes, he will give us the broad picture of the health disparity and equity requirements for people who are experiencing those structural value inequities and vulnerabilities. His full biography is on our website. So with further ado, I'm honored to introduce Dr. Naheed Dosani.
My name is Naheed Dosani, and I'm here to talk to you today about living and dying on the streets towards health justice through a palliative care approach. Today, I'm really excited to achieve a few important goals with you. The first is to highlight the impact of social disparities, for example, homelessness and poverty on healthcare outcomes. Number two, to introduce innovative healthcare interventions like the PEACH program, other research and advocacy efforts that have been aimed to address health inequities from my world to yours. And then finally, end off on a positive note, through 4 lessons learned from our work in palliative care for unhoused populations to collectively challenge this community to bring about a more equitable future for our healthcare system. Today, it pains me to report that homelessness in Canada is not just on the rise, but it continues to be grossly undercounted. For our country of about 35 million people, homelessness is impacting over 250,000 Canadians per year at 263,000. Sleeping rough or unsheltered is up 100%. The raw reality is that being unhoused is by definition, meaning that at some point you will deal with seriously ill health in Canada, because we have literally designed a home healthcare system that is structurally unable to deliver care, and in my case, palliative care, for people without homes. And so on July 1st, 2014, the PEACH program, Palliative Education and Care for the Homeless, was born as Canada's, actually North America's, first mobile street and shelter-based palliative care program, aiming to provide healthcare to unhoused people with serious life-limiting illnesses so that no person would die alone or fall through the cracks, whether on the street, in a shelter, or under a bridge. The PEACH program works for 5 reasons. Number 1, we strive to integrate health and social services in every way. Number 2, we bring a trauma-informed approach to palliative care. Number 3, we recognize that harm reduction is a human right, even when people require a palliative care approach. Number 4, we're flexible and agile to meet people where they're at outside of hospitals and clinics. And number 5, finally, we work from a place where we recognize that the system isn't broken, it was literally built this way. Framing is everything.
Thank you so much, Dr. Desani. I hardly know where to begin with. I'm sure many of our people on the call are also feeling the same way at the summit. It's hard to know where to begin, but there are some questions that have come in, and I'd like to start with those. There we go. First question is, how can we as patient groups best support the work that you are doing?
Yeah, thanks so much. I think, first of all, I want to say that you are doing it by being here, by organizing the structures you've created. You are already on a very good journey to making that a reality. I think the second thing is that as patients who know the system, know the systems that you want and need, you are really in tune with the models of care, the voices and approaches that resonate most with you. Maybe, Louise, that's why you and the team wanted to hear more about the PEACH program, and that's why maybe I'm here today. And maybe that's an example of why many of the speakers are here. By the way, it's an incredible group of speakers who are speaking. Many people I look up to and I'm constantly inspired by. And so I would build allyship and relationships with those individuals who are doing that work so that you can help empower their voices and they can empower yours. And then finally, I would choose policy points. And I tried to pepper the talk with several different kinds of policy points, whether it's about housing, and thank you, Louise, for your support with that. Pharmacy care, dental care, food security, social assistance rates. I mean, there, you take it, you name it. There are many different kinds of policies to choose. I would start to really get at the roots of those policies and make sound, tangible, action-oriented policy recommendations and suggestions, and then make noise in the ways that you know how to make it best. I truly think you're already doing this now. I think you will continue to do it with a louder voice as the years go on, and you can consider me an ally being right there with you all. Thanks.
Oh, thank you very much for that. There was also a question about what other stakeholders, such as industry and healthcare providers, can do also to amplify the work that you're doing.
Yeah, I think that we have to be very articulate and clear about how we are allying with different organizations and sectors and why we are doing that. I think one of the things that we have to continue to protect in our discourse is our national gem, our universal publicly funded healthcare system, which in various pockets across the country is at risk. You just got to look at the headlines today and you will see that in many places across Canada, there is a vested effort to sell off our public healthcare system for parts and for profit. We've seen this through COVID-19 and this trend continues. If you are partnering with industry, be careful about the relationships you're making. Be careful about what that means and the implications of that. That's not to say that that can't happen. That's not to say that that won't happen, but never lose sight of your core values. And I try to, make that very clear through the development of the PEACH program that we never negotiated on our values, never negotiate on your values too. And so I can see that industry will continue to be a part of these conversations, but we should always know what's at the core, and that's protection of our publicly funded healthcare system.
What about governments? Do you feel that, I think we could probably guess the answer to this. Do you Do you feel that they've not done enough to help with these solving these issues so far? And if so, what advice would you have about messages to deliver to them?
For sure. I would say that essentially one of the things that I would want to say is that these are complex issues that fall between the cracks of our social and healthcare systems. And if they were easy to solve, they would have been solved a long time ago. But that said, in the case of many of these solutions, we have evidence-based solutions right in front of us. In the case of housing, we know that building more social housing not only ensures people have access to housing, but it's cheaper for society in general. And so, you know, I get very frustrated when in spaces like that, we have the solutions. Food security is another area where we've had solutions for a very long time. We know that if we provide income supports for people, people are less likely to experience food insecurity. And so it gets a bit frustrating. And over time, you know, the government's various levels of government cannot continue to say that these are complex issues when the solutions are right in front of them. And I think that's where you come in. Your voice is so important. As patients, your voice is so unique. And so what I would say is that, you know, center the experiences of patients in the in the advocacy that you are doing. Tell stories. I call them narratives of compassion. You know, Canadians are listening and Canadians are compassionate. When we've ever gone out and told a story about the Peach program, we always center our work with the Peach program about patient voices. We've centered, you know, one of our clients in the Peach program or two, and the response has been immense and so compassionate. People really do care. And I think it's your experiences that will take this further. I think a summit like this allows us to combine the power of narratives of compassion, but also data and policy. And I think when we have that, you know, multi-pronged approach, we can really make significant impacts. So I do think all levels of government can and should be doing more. And I think the approach that we're taking at this kind of summit is a big step forward and is a tangible step forward to making that change.
Thank you. So you mentioned data, which was a note I made while you were speaking. You pointed out that the numbers of people who don't have access to social determinants of health is probably very undercounted, and that speaks to me about data. And governments are talking a lot about collecting data. I'm glad to hear that you're part of CPAC, because they've just put out a pan-Canadian data strategy that we hope will also help to close these gaps. What do you think? What do you think we should be ensuring as governments make the decision that they are going to do better about collecting and having interoperable data for people?
Yeah, I think it's really hard to make significant strides in policy change without having access to data. And data is, unfortunately, for those who are newer to the conversation, unfortunately so fragmented and so siloed. And when you start to take into account federal and provincial data, it gets even more challenging. And so I think at a patient summit like this, as you move forward, I would advise you to start thinking about what data recommendations you are thinking about collectively. One of the key questions that always comes up is who owns the data? You know, why can't, and I know you've been thinking about this since well before 2019. And for those who haven't read the Working Data Group's recommendations, over 30 organizations have signed on to support. It's because this conversation is so important. So who owns the data is a conversation that needs to happen. When data is collected, you know, how are we standardizing the collection of social determinants of health data? Here in Toronto, I'm proud to be part of a network of hospitals in Toronto that has integrated a standardized approach to collecting social determinants of health data. Why can't that be the norm across the province? Why can't that be the norm across Canada, right? And then finally, I do sometimes wonder about the collection of data for the sake of collecting data. It can be very frustrating. I can only imagine what it's like for patients who constantly are being asked to fill out surveys and provide their data when nothing happens with it. So I think patients deserve, a really clear depiction of, if you're going to collect my data, sure, but what's the action that's coming from it? And I think that's the kind of request, that's the kind of demand, maybe even that patients can be making at a summit like this for the future. So at a broad level, those are some of the things that I would be thinking about.
Thank you. We have another question that's come in. It says, what do we see as the enablers and barriers to creating some integrated healthcare approaches, and including allied health professionals in the work, and help to break down the silos between social care systems and health systems? I think there's a few questions in there.
Yeah, no, it's very fair. Just off the top, a very complex a question that I think could, deserve its own panel at a summit like this. But what I will say off the top of my head, that enablers in our Peach experience have been a very committed a pool of people with lived experiences of homelessness who have been resourced and supported to support the model. Peach wouldn't be possible if it wasn't for unhoused people who contributed to its development and work in the program. For example, our peer worker. There are many health workers who are very passionate about these kinds of connections, and I think there are many people who are thinking outside of the box. That's an enabler. I think another enabler is the research. There's a strong body of research that shows that we get better outcomes when our health systems and our social systems are not siloed and they integrate and talk to each other a lot better. So I think those are great enablers. I think the barriers come to some of the things that I've talked about, but just to say, funding unfortunately is a significant barrier, because when you follow the money, money is often siloed for particular purposes and in particular places. For example, it's very difficult to get federal healthcare money into the hands of a social service provider. I'm learning this through my federal work. It's a lot more challenging than I thought it would ever be. And why is that the case? If we're really looking to redistribute resources in an equity-oriented way, we have a long way to go, right? Around that. I think the other piece is, and maybe it's the palliative care clinician in me speaking, but I really think that this work is hard. There's a lot of moral injury, compassion fatigue, and it's very hard to navigate policy and systems to create that structural change. And people are burning out. People are experiencing that moral injury and that compassion fatigue, and people are barely getting through their shifts, let alone creating structural, changes to our system in the spirit of and trying to do that in a way that makes sense when they are dealing with so much inertia. So before we even start to have conversations like this, we need to address pay disparities around gender, pay disparities between community and hospital, pay disparities among professions. We got to think about policies like paid sick days. Like what does it say about our healthcare system that health workers don't get access to paid sick days? A known policy that has been shown to have evidence and strong evidence in healthcare research. I mean, come on, right? So there are some significant structural barriers, not to paint it all as doom and gloom, but until we address things in our own house like that, it will be somewhat more challenging to build these connections. But I really appreciate the question, because that was really what I was trying to point towards, is that we need to build better bridges between our social and healthcare systems, especially for communities who experience structural vulnerabilities.
You said something that really touched me. I mean, everything you said touched me, but this really touched me when you said that they wouldn't be in palliative care if they had been dealt with early. I'm not saying exactly your words, but this is what I understood, that if they had had the proper health care long before that time. And have you got any words of wisdom about for us about what we could do about that?
Yeah, it's happened before where I've spoken in, physical or virtual rooms like this, and people are like, you're a palliative care doctor. Who are you to talk about upstream social determinants of health? And my response to that is like, no. Think about it. There's no better place for someone to view the importance of upstream social determinants of health than downstream for people who didn't get access to good social determinants of health, because the inequities accumulate. And yeah, I really meant what I meant, Louise. Like at the Peach program, we care for people who should not be dying, but are dying because they didn't get access to housing, income, food security, social supports, pharmacare, dental care, a lot of the things you're talking about at the summit. And so they end up in the Peach program. Had they had access to that, I would probably never have met them. And so, as a peach clinician, my life's mission and work in venues like this, when given the opportunity, is to say, take it from me, that we take it from us in our experience, that a lack of action on this is deadly and leads to death outcomes. And so that's like part A. I think the part B is to take that experience and break it down into what it means in different spaces and places. I'm so encouraged to hear that this is not the first time you have been talking about social determinants of health and policies related to it at a summit like this. I know you've been talking about things like harm reduction, and I know I've talked about the other social determinants. I do want to talk about how, it blows my mind that in 2023, people who use drugs lack equitable access to healthcare in a multitude of ways, and a big reason is they don't get access to the harm reduction services that they need. And so we need to scale up harm reduction, and we've seen this vested effort by certain parts of the political landscape to actually deter the growth of harm reduction services, due to ideology, for example, when the evidence shows that it has worked and has really saved a lot of lives. Here in Ontario, 2,000 people plus are dying every single year of an opioid overdose death. That is not good enough. We must do better, right? And so I think that's an example I wanted to share with you, and I hope that resonates with you, and I hope that will stick with you as you enter these various conversations at the rest of the summit.
So there's another question that's come in, and it's to do with the report that's just recently been released by the Council of Canadian Academics, and it's about the value of data sharing in the healthcare system and for realm. I confess that I didn't know about this report until I heard this question, but I'll certainly find out about it now. Can you comment on this report?
I can't comment on the report, and Meg, thanks for sharing it. I'm going to add it to my bookmarks to read for sure. But what I can say is that even as someone who wants to do advocacy-based research, and if you look at sort of like my publications and what I tend to work on, it is research by way of advocacy. It is extremely challenging at times, a lot of the time, to get data at a larger level to make those arguments. It should not be that hard to get access to, provincial data, to federal data. It should be easier. I reflect on my colleagues at CIHI who put out an incredible report called Access to Palliative Care earlier this year. Please read it, check it out for those who missed it. And what I'll point you to is in the report, CIHI themselves, who have done a great job of measuring palliative care and access, admittedly wrote in the report that we need to get more data to measure inequities in palliative care. So just put yourself in my shoes. That makes it very hard to advocate for ending inequities in palliative care when we do not have the data to really illustrate how inequitable palliative care is. If that's true in the palliative care world, that's true in many, many worlds. And I think reports like this seem to be, a way that we can move forward. We just need to see the action. So, I haven't read the report, Meg, but I just wanted you to, get into my head a little bit and my heart about how it feels when we're talking about data. And we're always thinking about new ways to construct these arguments and move the movement forward, so to speak. And so, that's just something that I wanted to share with you as well.
Thank you. And just as a last point, I really loved your 3 circles with our micro, meso, and macro approaches, because to me, that gives everybody a place to help the system. And I think oftentimes people think this is just beyond me. This is too big for me, and I don't even know where to enter. So, just as a last thought, what about the micro, meso, and macro? What do you recommend to people who are interested in each of these, and how to kind of intervene? Where's the intervention point?
Yeah, thanks for bringing that up, Louise. And yeah, I mean, it should be said very bluntly that each and every one of us have a role to play, and each and every one of us can be involved in social accountability of our health system. And as patients, I have to say that you are core and central to this, but I know I've said that 1,000 times, so I'll stop. But I will tell you a little bit more about the avocado from the perspective of this summit. So just as a reminder, the avocado, social accountability framework developed by the College of Family Physicians of Canada talks about these micro, meso, macro levels. And at the micro level, we often talk about advocacy or social accountability that is at the patient level, one-on-one in your doctor's office, kind of, how is it affecting that one person in front of you? I'm talking from the clinician perspective, but as a patient, you're thinking about, your comrades who are patients that are accessing the system and thinking about them one-on-one. Then at the meso level, we're talking about more the community level or the neighborhood level. I've been told over time that the PEACH program is probably a pretty good example of a meso level response to homelessness and palliative care. And so what are, local responses in your community and your neighborhood that have been affected to address ailments in the social determinants of health or address health inequities? And then at the macro level, that's where we're talking about real societal and policy change. I might group a summit like this as a macro level, meeting of the minds of patients and real, change makers across the country coming together to think about how they're going to, join forces and encourage changes in policy, connect with politicians, and really make that work happen. Although some of you will take that knowledge and trickle it back to your local communities for meso and micro work. So again, it's the connections between, not to present this as boxes, but more as a continuum. And many of you will work on all three levels in different spaces and places. Some of us work at one of those levels and specialize in that, and that's important too, right? So we all do have a place. So I'm glad that the avocado really did resonate. It has resonated with me, and it's a framework that's helped me think about my advocacy and my role in this whole thing. I hope it continues to help you too.
Well, thank you. I hope you will continue to send out social media posts, because otherwise I wouldn't have met you and become such a big fan. And I'm sure a lot of other people would like to help, hear you. Keep your voice going in that way as well, because it allows us to amplify and to learn ourselves. So thank you so much. I continue to be a huge fan, and I'm just amazed at the work that you're able to do with your group at PEACH day after day. I can't imagine. So thank you so much for sharing all of your time with us today, and of course, all of your knowledge.
Thank you so much. It was such an honor. Have an amazing summit. You are incredible change makers and continue to inspire me each and every day. Have a good one. Thank you very much.
Thank you.
That was amazing. And again, thank you to Dr. Dasani for an invigorating keynote to get our summit started. For those of you who don't know me, I'm Antonella Scali. I'm the Executive Director of the Canadian Psoriasis Network, so a co-host of this presentation. I'm privileged to acknowledge that I'm located in the city of Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse First Nations, Inuit, and Métis people. It's my absolute pleasure to get us started with our first panel at this year's summit. This panel will talk about some of the long-standing systemic issues related to equity and oppression that Dr. Dasani already alluded to somewhat, that prevent people from accessing healthcare and that fundamentally impact on people's health outcomes. Specifically, our esteemed panelists will provide perspectives that address the barriers experienced by newcomers to Canada, racialized people, and older adults when accessing healthcare, and what they see as ways to address these barriers. This will be followed by a Q&A for the panel, so please continue to add your questions to the chat box so that we can address them as many as possible at the end. So it's my pleasure to invite our two panelists who are here with us today to join us. As a reminder, their full bios can be found on our summit website, but I'd like to officially welcome Hani Atan Alubidi, cross-cultural mental health specialist with the Winnipeg Regional Health Authority, as well as Birgit Umegba, critical care registered nurse, consultant, and public speaker, course course instructor, adaptive health leadership at the Graduate School of Medicine, the Cummings School of Medicine, University of Calgary, and clinical instructor at Centennial College's School of Nursing. And unfortunately, our third speaker today, Kiyasiw Lalji, Provincial Director of Government Relations and Government Programs at the United Way of BC, British Columbia, can't be here with us today due to a personal issue that came up unexpectedly, but he sends his regrets. And I will just introduce what he was going to speak about at the end of this panel, because his recording will be sent around. So without further ado, I'll turn it over to our first panelist, Hani Atan Alubidi. And thank you for being here with us today.
Good morning. Thank you very much for this introduction. I say good morning because I'm from Winnipeg. I don't know, depending on where you're at. Good afternoon to whoever is at 12 or after 12. I just want to say thanks for the organizers for putting this together. Thanks for the invitation and giving the opportunity for me to speak. I'm going to speak briefly. I haven't been feeling well, and I'm trying my best to attend and do my piece since I told the organizers that I will do so. So I'm trying my best to deliver on my promise. I also want to recognize and give my thanks to the Indigenous peoples of Canada for allowing a person like me, who's a newcomer, to come here, live, thrive, work, serve, and raise a family and be a citizen of this country. There are lots of things came to mind when Dr. Dasani was speaking. One of the things that he asked to find our version of Terry. The world is full of Terrys now, especially the images that we see in the news. Everywhere you turn, you'll find Terry. So unfortunately, it is very difficult and inescapable to not face a Terry in your life, especially if you are in a field that you care for people and care for those who need health care and so on and so forth. And so Terry is everywhere. That's how I can see it. That's how I think of it after I received this this invitation to think about our version of Terry. So I am speaking about today. I'm going to share some of the things that Dr. Dasani also have shared with us, but I want to just kind of keep it local and very focused to a very specific story that I was part of, which I'm going to share with you in a very few moments from now. But I want to just say that the theme of lived experiences, lived expertise, when they come together and employed in the right manner, they can go really far and they can serve effectively. So what does that actually mean? So I'm going to give you a little bit of background information in terms of the work that we do here in Winnipeg, and then we will zoom into a very specific story that I was part of, as I said earlier. And that involves another Terry, basically, another person from Winnipeg here. So why lived experiences and lived expertise is such a huge factor that is very much needed in our field of work to work with very specific population in our country, in our communities. Let me give you background information in terms of what I mean by that. And also my focus will be very much the mental health aspect of healthcare, because that's my role. I'm a family therapist, but also I'm a as mentioned, cross-cultural mental health specialist with the Winnipeg Regional Health. And through that role, I have the chance to speak with different practitioners through consultation, through one-on-one support, capacity building, reaching out to specific culture groups, utilizing the community resources to enable any specific treatment plan that is put by practitioners to deal with some clients or patients that they need specific care. I want to give a little bit of information about the fact that prior to 2020, here in Winnipeg, in Manitoba, we did not have any in-depth therapy, long-term treatment or therapy work that is available for newcomers. We had 6 sessions, I think 4 or 6 sessions of counseling available that is funded by the government, specifically the IRCC, which is Immigration, Refugee and Citizenship Canada Department Fund. 6 sessions to newly arrived refugees of counseling. And I'm not talking long-term therapy to address post-traumatic disorder or any type of trauma that will require care. It was few limited sessions, and that's about it. But that changed, and that changed due to the Virgo report that was done and released in spring of 2018, and it is a report that was provincially funded. And there were tons of recommendations, and some of the recommendations that came out of that report, it's focusing on the newcomers as a demographic group that needed specific support, help within the mental health field. A new program was established in 2020, and the new program called the Newcomer Mental Health Program. And in that, and through that, this program, any and every newcomer person, regardless of their immigration status, anywhere in Manitoba, can access in-depth, long-term therapy work or therapy services. And to me, that's a huge work. That's a big success. I am part of this program now, and I see the result. I see the impact that is making. I see the help that is offering. And so imagine like people did not have access to that for all these years. And now you have access everywhere you go to within Manitoba, you can have access to this program. Now, what is this program? What makes this program very special? I think some of the people who work in this program, including myself, we have lived experiences, but also we have lived expertise. And lived experiences, it is hard to translate into words because it is an experience, and the experience the person has to go through the experience in order to understand it. And so we use those terms trying to explain what that actually means, but it's really difficult to put them in words. But I'm going to tell you this story that I have, one of the people that I had the privilege to work with. And probably that term becomes easier to understand in terms of action, in terms of operation. So I had the chance to meet a 24 years old man, a war survivor, a person who witnessed some of his family members got killed in front of him. And a practitioner was working with this person. The practitioner, even though has partial exposure to the cultural background of this individual, but did not have a full lived experience or cultural knowledge. That cultural humility that connected the patient to the practitioner wasn't fully there, even though there are lots of attempts to make that happen. But that person got in a place of a stuckness, and the practitioner wasn't able to move the individual from that spot. I had the chance to sit with the two of them, the practitioner and the patient. And then we realized that there are things we're missing. And those things are very, very small cultural cues that we're missing. So we pointed out to those cultural cues, and then we moved on. Months later, the family and the community got involved. I was contacted, and I got reconnected to the family. This person that I speak about has a major depressive disorder to the point where he's jailed in his own room. He cannot bring himself to be motivated to either eat properly, go out for a walk, meet with people. Technically, he's staying on his phone in his room all the time. And he lost weight, but he also lost confidence, lost motivation in life. I had the chance to meet with this person again and his mother. And then we had a treatment plan done on the spot. When we connected, I had a plan for him to follow. And that plan wasn't very complicated. The plan was, since you don't eat food and you don't have the motivation to do so, today you go with the family and you just sit with them at the dinner table. That's the homework that I gave him. And the mother reported back to me, and she said he did it. He was sitting with us. This is maybe to many people, this is not a big deal, but to me, it was a very big deal. This very same person was invited to a group that I put together, a group of men, newcomers men. And we called it the Circle of Men. And he was part of it, and he came. He was motivated actually to come, even though it was in 5 p.m. in the evening. In this cold weather in Winnipeg, and you know, if you lived in Winnipeg or you heard about Winnipeg, Winnipeg gets cold. And especially for newcomers, can be shocking. But anyways, he made it. So he made it to this group, and he was part of it. And I was actually surprised to see the very same person eating 2 wraps. And now I'm not claiming credit for that, but I want to tell you what those culture cues were all about and what they did in the treatment plan, if we pay attention to that. Those culture cues basically meeting this person where he was at, culturally speaking, and being able to connect with that person based on what he wanted and needed. And then you move on with the treatment plan. It's not following a specific structured treatment plan that was pre-prepared and you just put it in the front of this person, and regardless of their challenges, cultural understanding, cultural motivation to understand, and so on and so forth. This family now are motivated to come to their sessions. They are able to understand that there's a person where they can see that understand their lived experiences, but also there's an expertise that match that lived experience. And with that, if you put them together, you create that motivating, culturally comfortable space for this person to open up and receive your treatment plan as a practitioner. I brought this example as just to back up what Dr. Dusani has been showing us this morning, and it was incredible work. And I thought it's incredible when incredible is for us to think about this phrase. What does this phrase mean when we say meet people where they're at? And we need to understand that from their perspective. It's not from our perspective, but he needs to have that depth in terms of listening, attunement, and so on and so forth. And I think this is just an example of many examples that he shared, but also I just wanted to add this person because this is an actual real story case that is taking place here in Winnipeg, and I am part of it. And I'm really happy to see the results because we used to hear those terms, but we don't know what they actually look like in real life. But now we can put a face to it. So I feel like this is an incredible, very motivating example, at least for me, to see a person that from stuckness to motivation and hopefully do something with his life. So um, lived experience, lived expertise, putting them together, employ them in the right moment, and put the notebooks away and listen to the cultural cues, understand people's circumstances, and we move on with the people that we serve together, co-creating a treatment plan or any action plan that change their lives. I think there's a limited time. I'm gonna stop, and hopefully, if there are questions, we'll be more than happy to answer. Thank you very much.
Thank you so much, Hani, for building on our keynote and giving us some really concrete examples from your work on what we mean by meeting people where they're at. And we do have questions for you. We're going to hold them until the end of the panel. So it's with great pleasure that I invite your fellow panelist, Birgit, to please share her screen and her video, and she'll be presenting next.
Good afternoon, everyone. Thank you very much for that great introduction to the panel. Thank you for this opportunity to be here today. It was such a great start to have Dr. Dasani speak. I'm just going to quickly start from, I have just a few slides today. Thank you, Leah, and thank you to the organizers for allowing space for this conversation. I'll be continuing the conversation today on the roles of equity and inclusion in the modernization of healthcare. First, I'd like to acknowledge the land on which I'm on today. I'm hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. I'm grateful to the original caretakers of this land, and I recognize the enduring presence of all First Nations, Métis, and Inuit people. So I'd like to start with this photo by Chris Bach. I work as a critical care and emergency room nurse in the GTA, and oftentimes as a Black woman who navigates a society that is predominantly white and also fraught with anti-Black racism, I often wonder where I belong in this society and where people who look like me belong. So here's a photo. This is an image that's meant to encourage others to challenge your mindset and racial expectations and then talk about it. So this is a little girl who's at a store looking to purchase a doll, but she's standing there and wondering why she cannot find a doll that looks like her. Bringing this to healthcare and how we practice as a nurse and in leadership positions, we see patients who view themselves this way. And we have a lot of patients who are from marginalized groups come into healthcare facilities and they're feeling that they're not represented in any way. So this is more a food for thought. First, I'd like to start with a story of Sarah. Sarah is a patient that I will never forget about. A disabled Black woman. Sarah battled not only a complex medical condition, but also the harsh realities of systemic oppression due to her gender, race, disability, and socioeconomic status. Sarah's experience underscores the urgency of redefining our healthcare system. Sarah's journey through the healthcare system was riddled with challenges. The barriers she faced were not just about her medical condition, but were deeply rooted in the social determinants of health, which are pivotal factors influencing an individual's well-being. We'll learn from Dr. Dasani's presentation how important the social determinants of health are. Her race and gender made her more vulnerable to health disparities, and her low income status exacerbated her struggles. During the peak of the COVID-19 pandemic, Sarah had to choose between going to work sick and putting food on the table because she lacked access to paid sick days. Eventually, Sarah caught COVID-19, was admitted to the ICU, stayed for months, and eventually suffers from long COVID till this day. How many times have we had patients who can resonate with Sarah's story, walk into our healthcare system with lack of access? Sarah's journey is a reminder of the many struggles that Black, Indigenous, and racialized people face in our healthcare system. So now let's transition from talking about Sarah to discussing the vital roles of equity and inclusion in the modernization of healthcare. I'd like to explain a little bit about the cappuccino effect. So as you can see here, we'll see a glass of cappuccino. It's just very visual. On top, we'll see how white it is, and at the bottom, we'll see the coffee and the darker colors. So this emphasizes the need for a layered and multifaceted approach to healthcare reform that values diversity, inclusion, equity, and belonging as essential components for addressing racial disparities, dismantling racism, and modernizing healthcare. How many times do we see how our healthcare system actually looks exactly like a cappuccino? At the bottom, we find the Black, brown, and indigenous people, and at the top, in leadership positions, we find more white people. And how can we ever talk about redefining or redesigning healthcare system, or modernizing our healthcare system without mixing the cappuccino altogether? Equity and inclusion are not mere buzzwords, but fundamental principles that guide healthcare transformation. To redefine the future of healthcare in Canada, we must first diversify the workforce. Our healthcare professionals and administrators must reflect the diverse communities that they serve. This will help break down cultural and linguistic barriers and promote trust among patients. As a nurse, oftentimes, I see patients with language barriers who are unable to express their needs to healthcare providers because we are just too busy to put those resources in place. In many cases, we do have translators in hospitals or healthcare facilities. However, we're often so overwhelmed that we're not even able to touch base with the translators or the interpreters to help with access to healthcare. Also, we must ensure that care is accessible and affordable to all, regardless of income or social status. We heard about that in Dr. Dusani's presentation about access is so important. Talking about patient-centered care, healthcare should be centered around the patient's unique needs and preferences, taking into account the intersectionality of their experiences. We must recognize that individuals have multiple layers of identity, which include race, gender, socioeconomic status. When it comes to dismantling racism in healthcare, we must focus on anti-racist healthcare, which allows the healthcare providers to receive anti-racist training to better understand the unique needs of patients from various backgrounds. Healthcare organizations must collaborate with community leaders and organizations to address the social determinants of health. How can we move beyond words? I'm glad we're having these conversations. I'm glad we're talking about how to move forward, but how can we translate our words into actions? Advocacy. Advocating for policy changes. By challenging structural racism, we need to push for policies that promote equity and inclusion in healthcare. We need to lobby for comprehensive healthcare reforms that address the social determinants of health. On a micro level, when we look at patients and we see how challenging it is for them to access the basic needs within the healthcare system, those patients who oftentimes experience racism, we must advocate for them. As a Black woman, I've experienced racism not only as a healthcare provider, but also as a patient. So I see it on a daily basis. I see patients experience racism at the bedside. I've been called a Negro by patients, and I have also seen colleagues who have been dismissed just because of the color of your skin. And this is why it's so important we provide education and training to encourage healthcare professionals to be better able to provide anti-racist and equitable healthcare. Actively engaging with local communities to understand their unique needs and ensure healthcare services cannot be underestimated. It's really important that we go to the level of the people and engage with them and participate and listen to their needs in order to be able to transform healthcare. Raising awareness involves being mindful of the various intersectionalities and social determinants of health that are important to equity in healthcare. In redefining the future of healthcare in Canada, it is paramount that we address intersecting oppressions by fostering equity, inclusion, and belonging. Together, we can build a healthcare system that meets people where they are and ensures that individuals like Sarah receive the care and support that they deserve. It's also important that we engage with other issues that impact people's health, like pay equity, Ontario Disability Support Program. These are vital issues in our society. We heard in the keynote that we are social subscribers. I consider myself a social subscriber. When patients walk in that emergency department, coming with pain or a wound that's been leaking for weeks and weeks and weeks, I want to know if they've been getting food on their table. I want to know if they have a place to lay their head. When we're discharging patients home, where are we sending them to? These are questions that we must ask and continue to ask. So when it comes to advocating for healthcare and modernizing healthcare, it is important that we address the social issues in order to be able to make any advancement. I like to end with a quote by Ijoma Olwo, which says, when we identify where our privilege intersects with somebody else's oppression, we'll find our opportunities to make real change. Thank you very much.
Thank you so much, Birgit. I must say I was very excited to hear from you and Hani and to learn from you both, and I am not disappointed, and I'm really looking forward to Q&A where we can continue to get your insights on these intersecting oppressions and how to challenge them. Just before I turn it over to you both for a moderated Q&A, I'm just going to invite you, Birgit, to please, if you stop sharing your slide, I'm going to pull up one very quickly so we can acknowledge our guest who was supposed to be here with us today, but unfortunately we couldn't. So just to quickly acknowledge Kiyasiw Lalji, the Provincial Director of Government Relations and Programs at the United Way, British Columbia, was going to be speaking on this panel about aging and care and intersecting oppression. So no one's left behind, because we know that in past summits, we've talked a lot about ageism and how care for older adults have been exacerbated since the pandemic. And we had a great presentation from Kiyasiw. Unfortunately, he's not here today, but we will ask him to record his presentation, and we will be sending it around to everybody who's registered for the summit. So we really look forward to sharing that with you when we have it. So I just wanted to acknowledge that briefly, but invite Birgit and Hani to please share your screens again so that we can see you during the Q&A. And I have some questions already coming in, but I invite everybody, if you have any questions, do just pop them in the chat and we'll address as many as we can today. I want to first thank you both for, again, your presentations and for also embedding your presentations into examples of your own TERIs. So you talked about Sarah, Birgit, and you talked, Hani, about the gentleman that you've been supporting. The work that you're both doing to advance some of the issues you talked about are incredible. And I just want to open up the Q&A with a question for both of you, perhaps starting with Hani. But what is one thing that patient groups can do to best support the work that you're doing? In this case, talking about some of the cultural cues and supporting people where they're at, Hani.
Thank you. So I think one of the things that we can do as a society first is to provide opportunity for growth for potential practitioners or professionals who are, let's say, with lived experiences, so they can be part of what we call system, because we always talk about system as if it is a foreign entity, but system consists of people, right? And so in order for us to see people or patients represented, or at least see themselves represented or reflected into the presence of certain practitioners that can be potentially hired to fill specific roles and gaps within the system. And those potential employees, I think, would play that cultural bridging between what we have of a structure, a system, as I think it's been mentioned by Dr. Dasani, and we heard it many times as well in different occasions, that the system was built with whatever intent, but it was to serve specific demographics, specific groups, specific community, and so on and so forth, specific needs. But the time is moving forward, and society is changing, and needs are also pressing us to come up with the creative solutions. And I think one of the solutions that we can have, or at least methods to deal with this type of situations when it comes to mental health, the healthcare system, it's to hire basically more people with lived experiences, so you can have you have that connection that we spoke about, which is connecting the patients to the practitioner, and they see themselves represented or reflected into in the healthcare.
Thank you so much. I'm going to turn the same question over to Birgit. We're patient organizations, a lot of us in the audience, and you do amazing work at the bedside, also in advocacy. So what's one thing that you think you want us to take away that we can do to support that work?
Yeah, thank you for that question, and thank you for that contribution. And I think I actually had a slide where I totally forgot to show that slide that talked about, advocating for equal representation of Black, Indigenous, and racialized healthcare professionals. And this could mean just literally asking why there are no other groups represented at the table. And even as patient advocate groups, who are those at the table, and whose voices are being centered? Because oftentimes we may be advocating for as opposed to advocating with people. And we end up talking over people's voices and not knowing what needs to really have. So I really do think that it's really important to have those voices at the table. And also, I know we don't have a system that helps us collect data on the success or even the challenges of this structural barriers, especially when it comes to reporting racism. And it becomes really difficult to monitor and to track. And I do know that there are a few scholars who are trying to work on that, but I think that will help. That would go a long way. And I remember very recently I was going to report an incident that happened in one of the organizations where I experienced racism, and the face of the organization was a white woman who actually didn't even understand the terms. She didn't even know what DE stood for, and she had to constantly pause to research who was in charge of the diversity, equity, and inclusion team at her organization. So, and that was meant to be the face, she was meant to be the face of that organization. So it just went back to, you know, performative allyship and actions and checking the box and making empty statements. So I do think that we have a role to play in asking who's at the table.
Fantastic. I'm taking from both of you. Our responsibility at whatever level in the avocado we work at is to look around us and look around ourselves and see who we're surrounded by and who's missing. And I will keep that cappuccino image in my mind when doing critical thinking like that, Birgit. So the program, it was fascinating, Hani, to hear updates from Winnipeg in terms of mental health services for newcomer populations since 2020. So congratulations, that's fantastic updates. And a question for you, what inspired the Manitoba government to start and continue to support this program?
I don't know what inspired them. I think we had a conservative government then, so but I don't know. We should put that question to them. But all what I can tell you is I think the voices of people who advocate, and that speaks to the importance of advocacy, especially if the advocacy offer alternatives. So advocacy, sometimes you make noise, but you don't create alternative to the current structure or system. But I think we have lots of people, and I'm very sure in every city in Canada you will have people who advocate, are creative, and they come and they come up with demands, but also with creative solutions, or at least some contribution to finding creative solutions. I think, look, mental health is it's a challenging area for many reasons, and I don't think we have the time to go in deep into that. But I can tell you this: whether you're a newcomer or an Indigenous person or whatever, a settler, as they say, or any person who lives in this country, in mental health is a very slow changing, slow moving type of process in terms of breaking through the taboo, the stigma, the cultural hesitation in terms of approaching mental health subjects, mental health services, and so on. So, but there were some voices and some people start talking about mental health and the importance of mental health. What we're trying to do in the newcomer population in Manitoba, in Winnipeg, we try to stay away from the conventional way of talking about mental health. And by that, I mean, we don't have to, there are things you don't have to talk about them as mental illness or mental health, but you speak about them as something that contribute to the well-being of the individual, of the community, and so on and so forth. So I think the government then, and also the society of the community, to answer your question, I think they saw the importance. At first, they saw the challenges, and then they hire someone, which is the Virgo report or the Virgo Consulting. And then they conducted a report in 2018, prior to 2018, but spring of 2018, we have, I think, 125 or so recommendations, and some of it covered the newcomer populations. And this program was created. And this program, by the way, even though I work with I work for the Winnipeg Regional Health, so with the province, but I'm still embedded in the community to work with partners from the community. And that's as a result of this recommendation that came out of the Virgo report. And this newcomer mental health program was created. And now we have a very comprehensive team that works with me. So we have a psychologist, psychiatrist, we have family therapist. We all as a team working together. So the patient or the person, the newcomer patient or the client comes in, they don't have to basically they don't have to go get lost into the layers of the system. They have someone like me, for example, navigating the system, link them to the psychologist on the team, psychiatrist for diagnosis and so on and so forth. And then long-term therapy that deals with PTSD and other type of traumas. So from that, I would say it is really a major change, because I remember a few years back, you barely have a chance to meet someone to talk about your challenges. So I think it's a major thing. But I don't exactly know to answer what inspired the government, but probably advocacy and collective voice and shared concerns.
Fantastic. I love the program the way that you described it, and I love that they actually actioned a recommendation in that report, and quickly. So that's hope for us that we can see that actually happening. So thank you again. And I also, before, there's a part 2 to that question, but I think I'll hold off and come back to both of you with that, and turn to Birgit for a question for her. But I just want to acknowledge too that both of you brought up integral components of the summit. So mental health and data, and collecting and utilizing the data that we need to be able to make better policy. And I just want to remind people that the third day of our summit, the 16th of November, is really going to hone in on 2 of those areas. We've got exciting panelists talking about spotlight practices and about mental health in Canada and how it's evolving slowly but surely. Turning it over to you, Birgit, one of the questions here is, what can we do to deal with the stereotypes we hear about racialized persons in healthcare?
Thank you for that question. That's a really good question. I want to start by, repeating what a friend of mine said to me a few months ago. And she said, how can you know another person if you don't break bread with them? And it's more like the closest way to learn about another person's culture is to break bread with them. And that can be translated to, our personal lives or even our professional lives, and just who are we breaking bread with in our different circles. Dealing with stereotypes is really essential to promoting understanding, fighting prejudices, and fostering a more inclusive and equitable society. So I really think it's important for us to start by examining our own biases and stereotypes, because we all have biases. I have biases, recognizing that everyone to some extent hold biases, and that's crucial to addressing them, because again, we cannot address what we can't even name or what we don't recognize. And then taking a step further to educate ourselves about, the experiences, the histories and cultures of people who don't look like us, or people who don't identify like we do. We can read books, watch documentaries, engage in conversations like this. These are powerful, spaces to hold the conversations, to broaden our understanding and think about actionable steps we could take. So actively listening to, experiences of people who engage and again, breaking bread with people from Black, Indigenous, and racialized backgrounds, and just encouraging that open dialogue and being empathetic towards the perspectives. And lastly, I would say allyship, true allyship, just being a part of the cause. And I think those are just some steps, some things we could do.
Excellent, thank you. Very helpful, and I think we can all take away a lot from what you just said, so thank you. Before I turn it back to Hani to ask some policy level questions, I wanted to ask you, Birgit, what do you see as working well to address some of the solutions that you see? So what do you have any examples of what you see as working to help ensure that we're helping leaders get to leadership positions from diverse perspectives and from diverse experiences? You may not, but I wonder if you have any I use the term enablers, but anything that you see as working, either in your experience or what you'd like to see, that we can kind of learn from?
I'm a very optimistic person, and I really, really hate to be pessimistic. But I like to be realistic too. As a nurse who's actually worked at over 25, 26 different hospitals, and so I've been around different hospitals, and so looking at just specifically healthcare settings, I've always try to see the positive as to what's happening in terms of diversity, equity, belonging. Where are we at? So I think when it comes to having the conversations, we're trying. These conversations are happening, but I have a very big challenge when it comes to moving from conversations to meaningful actions. I say this because I could scan across various organizations, look at their leadership team, look at the board of trustees, the board of directors, and oftentimes we get the token Black person, the token Indigenous person, and the token racialized person, and that's it. Is that something that's working well? I don't know. One or two, a lot of these token hires end up quitting, and because the culture is so toxic, they feel like they're just by themselves and there's no support. And so it's hard to say something is working well other than conversations. The conversations are happening. We're gonna have a Black History Month or again, and we're gonna, put out statements. And yes, we're talking a lot, but we need to see more of the hiring happening and that diverse representation happening so patients can feel safer as well as other staff.
Thank you. I do appreciate your perspectives and your experience and your realism, and I appreciate you helping us with this conversation. And I know that we're an action-oriented group, so we will do our best to take what we're learning here today and make it more actionable where we can. So thank you. And Hani, talking about action, I'll turn it back to you with kind of step 2 of the earlier question. One thing we like to ask our panelists is, what is one thing you would ask of government policymakers? And you have a very specific example where there was a report that looked at some issues in Winnipeg and made some recommendations, and some actual policy came out of that. Do you have any advice from your experience there for other governments or for advocates like us in terms of creating the advocacy, creating that collective engagement toward similar change and similar action in our own jurisdictions?
So if I understand you correctly, it's basically what are the advices that we can or experiences that we can share in terms of taking collective action that bring about local change where you at, and so on and so forth, at a government level or policy level. Look, I think when we say here's the situation that I'm always faced with, and when we speak about system and system change, we speak about it as if it is system is like an alien entity. The system is actually made of people who can be neighbors, it can be people that you go play sports with and you meet at the grocery store and so on and so forth. You're like people, like your community members. We need to see the motivation behind the change that we want to see reflected in any system I speak about is we want to see that beyond the system itself, but it is actually a nationwide project or a society project. What does that mean? It means people need to change their attitude and their understanding of having a society that is diverse. And the diversity is not the diversity, I know is a term that's been beaten up to death because we're talking about a very specific aspect of it. And yes, that can be very important. But if you want to talk about diversity, you have to include all elements of diversity, and you need to go deep and beyond what has been shared so far. So now if you examine what has been shared about diversity and what it means to a society like the Canadian one, what does it mean to have diversity? And people will give you the conventional answers because you see the focus is so much on one angle of that and they neglect so many other angles. And I think once we are able to expand on these type of conversations and make them accessible and encouraging to everyone, even those who we don't agree with, which I think is essential. It's to listen so we understand, and then people will see the practicality and the usefulness of engaging in conversations such as diversity, inclusion, and all of these terms. Those terms are being thrown and tossed around so often to the point where people think of them, some of people that I speak with and all that, they're tired of them, to be perfectly clear. They don't feel encouraged to talk about them anymore. So what I'm trying to share with you here is we need to examine, one is our conversations, how are they being run? Why are they being run the way they are? And then two, what angles are missing in our conversation? And the three, how do we sell those conversations to the wide and the large public so they feel, okay, you know what, I think I can see there's a share in it for me to join in and talk so I don't get automatically excluded. Because some people are driven out of those conversations because of shame, guilt, or they don't see themselves reflected in those conversations. So I think when we talk about system change, we need to keep in mind that the system consists of individuals. It's either government official or policymaker or a practitioner or service providers. These are all individuals. And if you can change thousands of policies, if the individuals are the same, they will stick to their old policies that are counterintuitive and counterproductive. So I think when we need, in short, we need to re-examine our approach in terms of certain belief system around certain terms that we use very often, and also the engagement and who do we engage and why. Or do we need to talk with the very same people that they always agree with us, or we need to engage people who are probably they want to just leave the room when we enter? These are the I think the first, I would say, prerequisite steps. Trying to stay in my role as a mental health person, not a policy guy or a politician, but anyway. So I hope I answered some of them.
I think you did, and I think your perspectives from a mental health professional lens of, conversation includes listening and taking into account what you're hearing when you're building your considerations and your conversation. So thank you for that perspective. We're out of time, I think, unless I get eyes from my facilitator that I can ask one more quick question. We're out of time. I'm sorry. I have questions still, but you both have been amazing presenters. I've been learning already a lot today, and we'll take everything back with this group so that in our breakout sessions, we can discuss some of what you've been sharing more deeply. So thank you, Hani. Thank you so much, Birgit. We hope that you'll be involved in some of our work going forward. We're sorry to have missed Kahir, your colleague on this panel, but we look forward to sharing his presentation around. And thank you to your openness to answering all of our questions, because we know they come up from everywhere. So thank you again.
Absolutely. Thank you.
And I'll turn it back over to Leah.
Thank you very much for having me. Thank you.
Thank you to everybody so far, both our attendees and our incredible speakers and panelists who have shared a lot of wisdom. I'm writing furiously over here. So now we're going to move into breakouts. Hopefully everything will be relatively technically smooth. So there should be a facilitator in every breakout. We will have a person circulating between the breakout sessions so that if there are any facilitators missing, we'll make sure that one is assigned to you. If your group is really small, because our registered numbers versus our actual live numbers are quite different from each other, your group can be brought together with another one so you can have a bit more of a conversation. So just give us a moment as we send everyone into their breakout rooms. We have until about 1:40 or so for breakout conversations, just about what you've learned so far. We're going to do another breakout session again at the end of today to continue to digest. And then we'll have about 5 minutes or so for bio breaks if you need some water, that kind of thing. But everybody needs to be back by 1:45 from those bio breaks, etc., so that we're going to be diving into our next two panels, focusing on two social determinants of health: housing and income. So with the magic of technology, hopefully we are all going to move into breakouts now. And apologies in advance if there is any technical glitch in the process. So let's see how it goes, guys. Hopefully we'll see you on the other side and breakout in just a sec. Welcome back into the main room, everybody. We've got a little bit of time left. If you still needed to run for a quick bio break, water, all of those good things, please do so now, as we will be moving into our second panel on housing insecurity in just a minute. So welcome back. Just take a last minute or two if you still need to address any personal needs, or just take a quick stretch and come right back because the content is fantastic.
Lee, can I ask a quick question? Are notes at the end of the day fine? You don't want them back on email right now,
yes,
right?
At the end of the day.
That's great.
That's great.
Thank you.
Thanks,
Thank
Ursula.
you. Okay. Oh, yeah.
I wasn't able to share the slides for some reason.
I didn't share them. I had one person, we were chatting, and then two more joined, so it's fine. I'll share some feedback later about breakout rooms, like with the organizers, but next year will be different anyway because they're going live. So yeah.
Hey guys, we are live at the moment. So that's thank you, Hanny. Really appreciate your presentation. So I am pleased to reintroduce Antonella and just prepare Bea and Diana, who are up next. So Bea, Diana, your panel will be starting momentarily. Antonella, come on board and get us started with an introduction.
Thank you. And I saw Diana's hand up, so we're happy to see you back here, Diana, and glad you could join us for the first part of our session today. I'm so excited to turn us over to our next two panels that will include experts in different aspects of the social determinants that impact on health. They'll take a deeper dive into some of the social challenges that we've already been talking about today that impact directly on people's health and what actions this audience can take to address these challenges. Again, we'll have a Q&A with all the panelists, so from the next two panels at the end of the next two panels. So please keep your questions coming in through the chat or note them down for our Q&A period at the end of panel 2. It's my pleasure to get us started with our second panel of the summit, focused on housing insecurity. Our esteemed speakers will provide perspectives both from lived expertise and from a service provider and policy lens and advocacy lens on the significant barriers people face to housing security and how they think that these barriers can be addressed. So it's my absolute pleasure to introduce Bea Lee So, with lived experience and is part of the Impact group and is an anti-poverty advocate, as well as Diana Chan McNally, community and crisis worker in Toronto's downtown east side, instructor in George Brown College's community worker program, and fellow of Maitri Canada and the McNally Project for Paramedicine Research. So I welcome you, Bea, to be our first speaker on this panel.
Thank you, Antonina. And thank you for the organization for having me in the panel. Good afternoon, everyone. We had heard a lot of excellent messages in the morning and early afternoon. Well, I will share with you my lived experience. I remember one Thanksgiving day many years ago, I stood at Flint Station, helpless and distressed. It's not because I was lost. It's because I was homeless and didn't know where to go. I worked very hard all the time when I came to Canada to support myself. But with high market rent, I struggled to pay my rent with minimum wages. After 1 month notice, I still couldn't find a cheaper place and was pushed into the street. I became homeless with a full-time job. Not knowing there's resources and hope and helps out there in the community, it was very, very hard to be homeless the very first time. And were you aware that I am a woman, vulnerable to be on the street? I use my head knowledge trying to keep myself safe from any assault or harm. I thought of staying at the subway station where there is presence of ticket wood collector, thinking that would be safe, but was disappointed because subway station closed at 2 a.m. God is good. 24-hour coffee shop came to mind. So I went to Tim Horton and stayed there all night. But because in my first time, so I couldn't sleep, even though I know I'm in a safe place. So to go through the night, then the next morning, I went to washroom, wash up, and I go to work. And it continued for four days. And then it came to Saturday, and I don't have to work. So I start feeling sleepy when all the customers came to the shop. And I was like tipping over, my head was tipping over to one side, and the customer pat on my shoulder and say, "Hey, you're going to fail." So I say, "Oh, thank you very much." And then I sit straight up, but not long, I fell asleep again with my head tipped aside. And the customer went to the to talk to the manager, and manager came to me and say, "Are you sick? Should I send you to the hospital?" I thought, oh my God, I'm in trouble. I said, no, I'm okay. I'm just very sleepy. But that night, I couldn't stay at that same Tim Horton anymore, afraid that I may cause trouble. So I moved to another coffee shop. So all these things went on and off. So from coffee shop, I went to emergency room, and sometimes couch serving at my friend's place. And sometimes I sleep in the TTC subway train until they close the last train. And just to wherever there's place to keep me warm, I'll go there, just to keep me out of street and be safe. But because of lack of sleep, I finally couldn't concentrate in the work, and I lost my job. It's not just a high market rent that I cannot find a place. It's also the stigma people put on homeless people. I remember my friend knew somebody who rented the whole house, and then one of the tenants moved out, and my friend said, go there and see whether you can rent a place. But when the landlady came to talk to me in the coffee shop, she said, no, I'm not going to rent the place to you. Because she think that I'm cuckoo. How can a woman stay in coffee shop for that long? And she's afraid that because she had young kids, she's afraid that I will hurt her kids. So with all the stigma, and on top of the high market rent, I was wondering, I'm homeless for quite a long time. But finally, with somebody's help, eventually I ran out of money on my saving. And to a point, I remember it was Christmas time, I didn't even have any money to buy food. And so I was just drinking water for 10 days. But thank God, I'm still alive. So somehow, God sent a messengers, and with his help, I didn't even know at that time you can apply for social assistance. So with his help, so I was able to get on a social assistance on OW. But we all, I think most of you know, with OW, the rent, the shelter money they give to OW is not much. It's only 300 something. So it's impossible to rent a good housing or adequate housing. And so all the housing that I'm renting was a peculiar housing. I remember one time, it was so bad, the moisture was, in my room from other room, shower or whatever. And it was so moist, my leg got so swollen, I couldn't walk. And then, one time, the other time, the backyard water pipe broke. And when landlord tried to garden to water the garden after the winter, and the water go to the next door because they didn't close the window, but it seeped to my room because my room was lower, and it was like, and I don't have a bed. I sleep on the concrete basement floor, and because of the water, I couldn't sleep on the floor, so I sit and sleep. And my friend, know that I didn't have a good sleep, so she pay me to get out and have a sleep at Jackson Point Salvation Army Retreat Center. But because I'm so used to sit and sleep, I was tossing here and here and there, and couldn't sleep. But when I get up and sit on the chair, right away I fall asleep. So it was bad. Until this point, I still sit and sleep. And so it's not good for my health. And then the basement, because of the flood, it was infested with mosquito. And I'm very sensitive to mosquito. And I only sleep 2 hours. So that is the last place I had. And even though the condition was bad, I tolerated for 7 years because I knew when I move out, I'll be homeless because I cannot find another place that is cheaper or same amount of rent. But unfortunately, my landlord sold the house and I became homeless. That time it was during COVID lockdown, pandemic lockdown. And I tried to go to shelter, but the day before I was that time I have a place to go, a shelter, but the day before I was supposed to go there, there's an outbreak in that shelter, so they say don't come here, and then they refer me to this place to rent to this place. It was so expensive, $700, sharing with two guys, everything in a basement. But for temporary, I thought I'll go there, you know, instead be homeless on the street again. But after 2 hours, I packed everything on the van. And after 2 hours waiting, the landlord came to me and said, go to shelter. You're not welcome here because of your age. I know the answer why he don't want to rent it to me, because he is afraid that I cannot pay the rent, because it was $700 per month. And with my social assistant or OW, even I cover with my basic money to the rent, is still like barely I can, you know, manage. Yeah. So anyway, I end up to go to this place that my previous tenant, not tenant, my previous house tenant, they have been looking, and then some places they look, they don't want to rent. So he said, why don't you check it out? Maybe they still vacant. So I check it out, and it was vacant. So I went there, but I don't really want to go there because I have to share everything with a guy, a man. And but my friend who are helping me moving say, you should go instead of be on the street. So I say, under one condition, I will go there. If I can rent temporary, not under contract of 1 year, because I don't think that place is suitable for me. So the landlord, you know, since it's empty, sitting there, no income coming in, so he said, oh, it's okay. It's okay, you can go, you can come and rent. So I went there and rent, but I got assaulted, you know, by that man. So so there's a lot of challenges. A lot of challenges with low income, you know, depending on social assistance. It seems bad, you know, to be homeless, but there's also good thing come out from that homeless experience. Because of homeless, and I need, because of social assistance, I need to have a phone, but I don't have a phone. So they say go to a community center and get the 3 months voicemail. So I went to that community center, and then that time I start discover, oh, there are so many resources out there. And to that drop in, that time the city is cutting 20% of the drop in. So they say, okay, we need somebody to go and talk to the city. And nobody want to go. And that time I was already housed. And I say, well, I'm not homeless. So, you know, I shouldn't go. But nobody want to go. And then God spoke to me, you have to go. I said, what are you going, what am I going to speak? I'm housed already. God give me 2 points. So I went there and speak. That, you know, 1 point is that drop in is like my family, because I'm alone by myself in Canada. And then second point, with the cuts, homeless people, senior, where they're going to go and socialize. So I went there, you know, a lot of people, community agency was, you know, there, but cities, after that meeting, cities still cut the 20% cut to the drop-in or community center. And then after that, I was having this civic engagement class. And then the manager came to us in the class and said, we need someone to go and depute this interim poverty deduction strategy. And then she asked somebody to come and teach us how to do deputation. And after that, they say, okay, who can go? Nobody want to go. And everybody point to me and say, you have to go. I say, I only had one sentence. I was homeless with full-time job, nothing else. I don't know what to talk. And then I said, okay, I'll try. If I can write more than that, I will go. And then when I really sat down and think, all my homeless memory came to mind. And I start writing. And then I sent a copy to the instructor. Instructor said, it's good. Go register and depute. So I went, but God is very merciful. I think my first sentence caught the mayor and the city councilor, because I told them I was homeless with a full-time job, and they put a motion to only allow 3 minutes instead of 5 minutes. But then I didn't get cut. I got 4.5 minutes without cutting. Not even that. I got an standing ovation from that deputation. So God is good. And after that, in November, that was June. In November, it's the final poverty deduction strategy deputation. So I spoke again, I depute again, and then thank God it was passed. But at that, after the second poverty deductions, the final poverty deduction strategy deputation, God spoke to me, go and teach people how to fish. So I decided I said, I don't know who to teach them. You have to bring people to me. So God brought people to me, so I was able to teach them, to how to advocate for themselves and their community. And to cut it short, so and it just paved the way, and for me, the door was wide open, and I start my advocacy journey as an anti-poverty advocate. So I mainly focus on 5 areas because it's so big poverty. So I'm focused on 5 main areas: housing, transit, employment, food insecurity, social assistance, and anything related to poverty. Try to bring a systemic change or policy change. And also at the same time, also I try to train people, the committee member, to learn and to depute. And with that, God just multiplied people, more people, come and learn. And I told them, now it's your turn to go and teach other people. And so homelessness, really, we can change and we can end homelessness. You need 3 levels of government to come together and work collaboratively. I can even, I talk to a lot of homeless people, and even some of them say, you should run for councillor. I said, no, not yet. I'm building my base. One day, maybe. And they say, we go to support you. I said, okay, support me when the time comes. And even talking to them, I can find out there are 7 types of homeless people. Like one is like me, can pay high market rent. And second, they have a family issue, Like I talked to one person, he was homeless because of grieving of the spouse. And then the third one is people become homeless because they have mental issue, and their addiction, they cannot keep the house. And the fourth one is some people, they are seasonal worker. In the summer, they work as like construction worker. They work in the summer, but when it comes to winter time, they have no work. So they try to they come to the shelter or out of the co-program just to save money on rent. And then there are people who have low wage but want to buy a house, so they try to save money, so they come to the shelter or warming center or out of the co-program just to save the money on rent. And there are people who are encampment. They cannot be bound by four walls, and then they stay in a park. And there are people who came to Canada thinking that Toronto is a big city, it's easy to find a job. Those are like refugee or asylum people. And so so there's a lot of things to do we can change. We have already heard this morning about what Dr. Dosani suggests. So I have come up with 4 points. So first, we need to increase the social assistance shelter money. With that money of 300 something, there's no way to even get a room, in the basement sharing with so many people. And then the second, to prevent people, become homeless. Second is to increase the Canada Ontario housing benefit so people are able to pay high market rent. And then the third thing is to build more, not just affordable housing, but deeply affordable housing, or all kind of housing type, like RGI, supportive housing, mixed income building. And then, but no matter what, prevention is the key. I mean, city have some program, to prevent people from become homeless, like EPIC for eviction, rent bank. It was loan before, now is grant, to people with low income. But I think maybe city need to work more and increase the amount of the money. And then the last thing is to increase the wages, not minimum wage, but living wage. With inflation, everything is high now. Food price is high, everything is high. So with that minimum wage, you just can't go anywhere. And I like to end my sharing with something exciting. Who can imagine homeless people like me that will build home for women? And it's only God that will make this into realization. I was prophesied some 20 years ago that I'll build home for women. And at that time I thought, oh, no way. I'm not involved. I was deep in depression, and I don't really know involved in any woman group or any ministry. But what God wants to accomplish, He will bring and connect everybody together and get things done. And I got connected to this agency, IRIS. I can't remember the whole wording of that short form, IRIS. So we have been meeting, and we have met the funder, and if everything goes smooth, the building, 4-story building for women, will be completed in late fall 2025. God is good. Thank you.
Well, thank you so much, Bea. I've learned so much from your presentation already, so you really got us started. Thank you for all of your advocacy work, and I think you're building your base a little bit more too, if you're still thinking about running for office. So it's my pleasure to turn it over to your colleague on this panel, Diana Chan McNally. Thank you, Diana.
Yeah, thank you. And thank you so much, Bea. I'm actually a giant fan of your work. So it's always nice to see you and be able to present with you. And I think what's important is that folks like you, people who are currently experiencing homelessness, are the ones who have the most voice in these kinds of conversations. So, I think one thing that's really important in listening to you and listening to Dr. Dasani earlier today is that when you are unhoused, you are basically systematically barred from decision-making over your own health, your own welfare, down to the smallest decisions that we take for granted every day as people who have more resources, who are housed, when and what you eat, for example. So if you live in a shelter, you go to the drop-in, there are schedules that you have to plan your day around that are completely inflexible if you want to eat at all. So that kind of decision-making is entirely taken away from you when you don't have housing. So down to the smallest decisions, that is not within your control most of the time, which is incredibly egregious. And something I think that people don't realize is that, you're talking about being on the street, but also working a full-time job. Being homeless is a full-time job into itself. The amount of work that you have to put in every day to meet your own survival needs is immense. And I don't think people understand to what extent that has a burden on you physically as well as psychologically. It is work, and it is a lot of work, and probably harder work than any of us really has ever done if we've not been on the street in the same way. So I do want to say, the reality is that our ability to make choices, and again, even small choices, my being able to go to the Shoppers Drug Mart and go to the shampoo aisle, for example, and say, you know what, there's 40 kinds of shampoo here. I'm going to decide which of these I'd like to purchase. It seems menial, but that kind of decision-making, again, is without your control. But having the ability to make choices, even small ones, is the essence of freedom and of autonomy. And it is to say that if you are someone who doesn't have housing, you don't have autonomy. You are forced to be dependent on systems and to work according to the way they are structured without any real ability most of the time to have any kind of decision-making or input or control over how these things are actually structured. So people are basically systematically denied access to restructuring homelessness services and systems, which is incredibly problematic, as we should understand. In our service, again, I work in homelessness services. I work frontline in a drop-in. I've always worked in drop-ins for the past 10 years. This is where I've landed in terms of my work in the homelessness field, so to speak, poverty sector. Food is donated, so you don't have control over what it is that you're going to even be serving that day. A lot of the time, what we actually have donated is not adequate for a lot of people with special dietary needs. We get a lot of pork, for example, which doesn't work for a lot of people. We don't often get a lot of healthy fruits and vegetables, which has a toll on you physically in terms of your health and welfare if you're not accessing proper nutrition. Again, those serving times are structured, and meals tend to be first come, first serve. So if you don't make it in time because you're running around trying to get other resources, or you're stuck on the TTC, or you have an appointment, it's really feasible that even outside of you not having money, even those free resources that may exist, you may not actually be able to access them and get what it is that you need. I would say, in our services, there is a real tendency to paternalize as well. And I've worked, again, in so many different drop-ins across the city of Toronto, where when somebody does come late, I've seen workers blame that person for not making it on time. We don't know what's going on with them. We don't know what they're going through, where they've been, or what could have created the barriers that they weren't able to make it on time. There's so many different things. And if you're not sleeping, you're not working with kind of a 9-to-5 capitalist schedule, it's hard for you to keep track of what time it actually even is, in addition to just running around trying to access these different resources. So we tend to paternalize. We tend to say, because you came late, because you weren't here according to the way that we structure our services, we're going to deny you those supports. And that's disgusting. I hate that it's actually inbuilt into a lot of our services, that this is the way that we react to people, and we're not accommodating to them in ways that actually take into account what it is that they're going through. And I want to stress that what they're going through is ongoing daily trauma. People, again, have this bizarre idea that you are lazy if you're homeless. But as I said, it is actually work, and it is the hardest work that you will ever undergo in your entire life if you're actually surviving like this. So it's unfortunate that we have this tendency to paternalize and blame people for their own homelessness and poverty and withhold resources from them as a result of it. So I know I work in this sector, but I have a lot of criticism for our sector and how we're not actually supporting people in good ways. And on top of that, we're not really addressing a lot of the systemic barriers and the oppression that's deeply embedded in that, in those systems, and actually advocating against them. In my sector, we have folks like B, someone like me, I do some activism as well, but generally speaking, our sector is not very activist focused. We are not focused on advocating for the people that we are actually serving. And more importantly, we're not giving the tools or supporting people who are experiencing homelessness to be able to advocate for themselves. We tend to assume that people can't make their own decisions about their health and welfare, and we will make these decisions for them on the daily. And worse, if they do not like the way that we're attempting to support them, we tend to punish them for trying to exercise their own autonomy and have their own voice about what kind of care and what kind of resources they actually need. So I do want to stress that not listening to people has extremely deep consequences. I think in this room, we probably broadly understand that because all of us are here because we are talking through this conference about patient advocacy and are likely advocating ourselves. But you know, I have a history of homelessness myself as a teenager. I was kicked out of my house. I actually got pregnant. I was kind of a bad kid. Maybe still a little bit of a rebel as an adult. But as a teenager who was unhoused and either couch surfing or on occasion, I would be squatting somewhere where I could find some kind of indoor space to go. You're talking about Tim Hortons being 24/7. They weren't when I was 15 years old. So I had to find abandoned spaces, for example, and was pregnant while doing this. I remember actually going voluntarily to Children's Aid. I wasn't referred there. It wasn't something that was mandated. I went there because I had an expectation that if you are in trouble, they will help you. And what I found instead was an incredible amount of barriers to actually accessing what it is that I needed. Part of that was because I was unhoused. Part of that too was because I was femme presenting woman, young girl, and on top of that, also pregnant. So there's all these intersecting layers of stigma that kind of surrounded that. And what I experienced from my workers is that they told me what they thought I should do, which in many cases, even I think if I just tell you now, would not have been healthy or helpful. So I was told to drop out of school. And to go to a different school for burdensome young people like me. But all my supports were at school. I had teachers who helped me go to the doctor, for example, and it was some kind of normalizing factor in my life that if I consistently went to school, I felt like I could keep my life in control. So I actually did the entire time and ended up only missing 2 weeks of school. But because I wouldn't actually do the things that they kept telling me to do, drop out of school, go on OW, go into this group home for young girls, they said that I was an unfit parent, basically for advocating for myself. And so I actually lost custody of my daughter once I actually had her. And I think for a long time after that, didn't want to have anything to do with this field at all. But since then, obviously, I've moved back into work doing this kind of work. And even though the kind of lived experience that I have is not current at all and not reflective of a lot of other people's experiences, it does give me some kind of understanding of the kinds of barriers that people face and what the kinds of consequences that can result, which can be incredibly devastating for people. And not just things like losing children, but losing your life. Losing essentially everything and all supports and resources you have access to, which again can have incredibly devastating results on you. I know what it means, again, to navigate health and social services. And, you know, I deeply respect patients and other folks who are on the service recipient end trying to advocate for what it is that you actually need, because I know, again, how paternalizing that can be and how much that people will assume that they know what is best for you, when the reality is that all of us as patients, as people in receipt of services, we know what's best for us. So I try to take that into my work now. And in many ways, I think about the workers that I did have and think, do the opposite of that. Center the voices of people that you're actually supporting. Make sure that they have the ability even to make small choices in what it is that we're able to provide. So if somebody asks me for socks, for example, I won't just bring them any pair. I'll bring them a selection and say, take as many as you want, or take whichever ones actually, or whichever ones you would actually like. And it seems so small again, but as I said, these choices are taken away from you systematically. So even something small like that is giving somebody back their autonomy. In my work as well, though, I like to structure a lot more kind of formal engagement to make sure that we're getting good feedback from people. And some of that is informal. It's just literally just hanging out in the drop-in and engaging with people, asking them what's up, how things are going, if there's anything that we can do better. And making sure that I'm constantly in the loop and soliciting that kind of feedback from people. Now, I think a lot of homelessness services, you see people often just sitting in the office and not engaging. And a lot of the way that we're structured is actually quite carceral in nature. We don't engage with people all the time. We really create these barriers between us and them instead of actively soliciting that feedback constantly about what it is that we can be doing better for people. So, that can be informal, but it can also be formalized as well. So, things that I've done as initiatives in drop-ins that I've worked, surveys, which, Dr. Dasani was talking about, well, what does that information, how do we use that information? Is it actually given to folks as well to be useful for them? I try to make sure that whatever information we're collecting is non-invasive and is very much about actually restructuring our services in a way that makes sense given on the information that we're being provided. So I like to make sure that we connect those. And if we're getting that information from people, extracting it, that it isn't just one-sided. It has to be useful to folks as well who are utilizing the services. Otherwise, if you see no change in the services that are being provided, what is the point? What did you actually do this survey for? Ultimately, if it's just for basically just visually just trying to seem like you're doing a better job, well, that's not good enough. You actually have to take this information and actually make sure that your services are restructured or make more sense according to the feedback that you're given. So surveys can be one tool, suggestion boxes can be another tool. What I really like to do are town halls so that it can be weekly, it can be monthly. We actually give space for people, effectively a soapbox, to talk about whatever is on their mind, but also to ask them questions about how they feel about things are going within the drop-in space, what they might like to see, what could be done differently, what respect looks like, and all these different things so that we actually give them a formal space to speak and be heard, not just by other drop-in members, but by the staff, so that we're very intentional in being present for when these town halls are actually happening. And again, to take that information and to reflect meaningfully, thoughtfully on it, and to implement whatever we can and whatever may not be possible to have good conversations about what could be done in lieu. So I think it's really about, again, that very active engagement and soliciting feedback, but also acting on it in a good way. In the past, I've also done codes of conduct, which I should probably have thought of a better name for that because it sounds kind of just very carceral in nature. But, one thing that I found in a lot of homelessness services is that they might have codes of conduct, but those are structured entirely by the organization. And I think that's problematic. I think we should be talking to people about what it is a space should look like, what safety means in that space, and what respect looks like, not just between fellow members of the space, people using the services, but how the staff can be respectful of people who utilize the services as well. So in one case, I sat down at a table for like 2 weeks straight and just had all these Post-it notes and paper and just invited people with snacks. Come and go as you like. You can drop in, you can spend the whole day there, or you can just take a look. It's up to you how much you want to engage, but I'll be stationed at this table and you come and tell me, and I'm going to ask you questions like, what does respect look like in this space? And from this kind of engagement process for 2 weeks, and the more I just sat there, the more people really got involved. We managed to put together with constant input, constant feedback from people, we created an actual code of what respect looked like in the space for everybody, including staff. Unfortunately, I did this work and the organization didn't actually implement it. But I still feel like that was a good process to go through. And at least from my end as a staff person, I was listening to what they were saying, and at least in my own practice, I could implement that code of conduct and ensure that I was at least being respectful of people in the space. So unfortunately, it didn't get kind of translated into the organizational level, but at an individual level as a worker and some of my coworkers as well, we really took to heart what we heard there and tried to adjust our work accordingly. With shelters, and I've heard you speak at length about what it's like to live in a shelter, and I've been very fortunate in that I've never lived in the shelter system myself, but I've worked with now, probably hundreds, if not thousands of people who have lived in the shelter system. And what a terrible place, truly. If we're talking about engagement, there are two public services where you're never actually going to be soliciting feedback from people. One is a jail, and the other is the shelter system. So in both cases, we don't have formalized engagement tools beyond the occasional survey, which again, doesn't get utilized in ways that are visible to people who use the services. Beyond that, there is no real engagement with people who live in shelters to understand, do these rules make sense? Does it make sense to have curfews like this? What about these bed checks that we're implementing all the time? Does it even make sense, or is it invasive and in some cases traumatizing for someone to be asleep, say, in their room and have a staff suddenly burst in during the middle of the night and wake them up? A lot of people that I've worked with find that extremely traumatizing of people, especially people who have survived sexual assault, for instance. I've heard from a lot of women, they may be just in their underwear in bed, and then a male staff will bust in essentially to do this bed check. Well, that's not a good way of doing things, clearly, if people are being traumatized and triggered by it. But at the same time, we don't give people the ability to have proper feedback and say, actually, we need you to stop doing this. And there is no adjustment for individual shelter residents as well. It tends to be this very universalized approach, which doesn't take into account people's particular experiences and particular traumas, and actually adjust in a good way for them. So I really hate this about the shelter system, and I think it's something that really significantly needs to change. And one thing that I have advocated for, and it wasn't even my idea, I think, again, the thing about this work is that we need to be intentional in really listening to people who we are working with, because they have the answers. This is the thing. They are the ones who have the answers, but we, again, tend to academicize and politicize so much of our work to the extent that we are very paternalistic in saying that you don't know what needs to be done, but maybe we do because we've studied it and written papers on it. Well, I disagree with that at length. And I think, again, the voice that should be prioritized is the voice of people who are actually homeless themselves. So with the shelter system, again, it wasn't my idea. This came from work that I had been doing with people living in encampments. It was called A Path Forward, and it was a set of policy recommendations that we wanted to put forward to the City of Toronto following some of the very violent evictions. And we saw some photos from Dr. Dasani this morning of what those evictions looked like. And the idea was to stop that kind of very militarized violence from happening in encampments, understanding that it doesn't solve homelessness, it just commits harm against people. And we needed a better way to actually make sure that people who lived in encampments were supported according to human rights standards. So I worked with people who were currently living in encampments, I worked with other advocates, and I worked with city councilors as well. Sorry, to create this policy document, again, called A Path Forward, which was, again, meant to stop encampment evictions and actually prioritize a human rights-based approach to supporting them. Unfortunately, our former mayor was not a fan of this and was a very paternalistic person in terms of stating that the shelter system is safe. Anyone who doesn't choose to go in there is just causing political problems. They're protesting. That's why they're not going into the shelter and living in a park instead, which is absolutely ludicrous. No one's choosing to live in a park if they have a better option. That's the reality of it. So it didn't actually land anywhere. But one mechanism that was built into this was the idea of an advisory council of current and former shelter residents who have meaningful input and control over how shelter services are actually designed. We don't have that. And in fact, we don't have a lived experience council that is formalized to have that kind of control over any elements of services that are geared toward that particular demographic. So it's something that I heard when I was working on this policy document, and I've taken this forward and will continue to push for it because, again, I might be an advocate and I know a lot about the work that I do, but I don't know it better than the people who are experiencing homelessness right now. So it's not for me to be the ones to speak for them, and it never should be. We advocate, but ultimately, again, we want to make sure that the voices that are heard, that are prioritized, are the people who are currently homeless themselves. So that was the idea. It's something I'm still working on. I'm also still working on making sure that we have third-party audits of the shelter system, because right now they're internally reviewed only, which means that a lot of the time when we have issues where people get kicked out for ludicrous reasons, and there's no standards, there are technically standards, but they're not enforced in a good way. People get kicked out for things like being annoying, quite frankly, not for actual legitimate health and safety reasons, but because they are seen as problematic to staff. I would like to see third-party audits come into play as well, so that these kinds of things stop happening. So I'm still working with a lot of the people who come to my services on a daily basis. I'm working with other advocates who have experience of homelessness, including current experience, to make sure that we build in these better mechanisms so that, again, the voices that are prioritized are people who are houseless themselves. Thank you.
Amazing, Diana. I know you could give us an entire summit on your experiences. Thank you for sharing your experiences. We're honored to have you both here because we know the great work that you're doing for the communities that you support and that you work in. So thank you, and we'll be back to you at Q&A, okay? Right now, it's my pleasure to turn it to our next panel that's focused on income security, and we'll take a deeper look into the significant negative impacts that income insecurity has on health. Our panelists, one who's here live and one whose presentation will be aired, a video recording will be aired, will provide perspectives on how income security plays a crucial role in determining health outcomes and what can be done about it from a provider and policy perspective. So it's my pleasure to introduce Dr. Trevor Morey, palliative care physician with the PEACH team that we heard about earlier, an outreach team, as you know, that provides palliative and end-of-life care for people experiencing homelessness in Toronto. And the recording that we're going to air is by Alexa Ferdinand, a PhD assistant professor in the Faculty of Science and Technology at Athabasca University. So Dr. Morey, it's my pleasure to turn it over to you.
Thanks, Antonella, and really appreciate to be here today and be invited to come chat with everybody. And always great to see pals like Nahid and Diana and be out doing great work like this and sharing their experiences as well. So I'm one of the physicians with the PEACH team, so I work alongside Dr. Dasani. And I missed his keynote this morning, but I'm sure he gave everybody some good food for thought. And so I just wanted to kind of give a practical perspective building off of what Bea and Diana were talking about in terms of housing, but to focus on income support and with a very Ontario perspective, but I'm sure a perspective that applies all across the country. And with the same lens, as Diana was saying, I think I'm able to share the stories of my clients, but I think that really what's important is bringing, being able to have clients share their stories themselves. And I think what's really challenging is that, like Diana was saying, there's lots of people who get labeled as being annoying, and by annoying, it's just people trying to advocate for their rights and to advocate to change a system that is clearly broken. And I think what's interesting is that as a physician, Dr. Dasani and I, we have the privilege of being invited into rooms where people will listen to us. And if we can share somebody's story that we've encountered, then maybe it will lead to a change somewhere down the line, or we're able to get those people into the rooms to have those conversations themselves, which is great. And so I think the way that I like to think about things is that with the concept of structural vulnerability, which I'm sure Dr. Dasani talked about today. And I think framing it that way really focuses on the structures that are in place that make people vulnerable in the first place, and that are really set up and designed to keep people living in poverty and used in this very capitalist colonial setup that we've created for our society. And I think that there's kind of no better example of this than the way that we structure our income security system in Ontario. We have two kind of basic support systems for people who are under 65. So we have Ontario Works, which everyone would qualify for, and then ODSP, which you need a medical diagnosis and a disability to qualify for. And so just pulling up the rates for July 2023, a single person on Ontario Works gets $733 a month. And if anybody could find somebody a place to live for $733 a month, I'm sure, speaking to like what Bea and Diana spoke to, it's just crazy to think about that. And yes, there's CPP disability, but also OAS and GIS for the older crowd as well. ODSP is $1,308 a month for a single person, which is also something where trying to find a one-bedroom apartment to rent in Toronto would be near impossible unless you find somehow a way to get into the rent gear to income housing list, which, you know, the waiting list for housing for that is extremely long. And to be honest, a lot of the clients that we see with Peach have a prognosis or a life expectancy that's less than the wait list for housing sometimes. And so it's a lot of us kind of going out and trying to beg people to find something to work for somebody. And I think what's interesting with ODSP, with CPP disability, is that really what you're doing as a society is kind of getting people to go through all of these administrative hoops to go see doctors who often people don't trust, to try to find a doctor to fill out these complicated forms for you when you yourself are very sick and have a bunch of different medical appointments to attend to. And I think one of the biggest interventions that we make with our team would be filling out these forms to give somebody, to switch somebody's income from, you know, $733 to almost doubling that to $1,308, which is still, you know, keeping somebody in poverty, but gives them some tools, you know, when they're going, you know, every week to the hospital to get treatment or to get investigations, or, you know, just trying to get by and find a place to live, to try to find some food to eat. It's a pretty wild system that's been set up. Not to mention that when you turn 66 and age out of ODSP, there's really no good system that really will connect you to GIS and OAS. And you're, you know, if you're somebody who's already living with a disability, that whole process of switching from ODSP to GIS and OAS, the kind of federal income support program for older adults, you go from $1,308 a month to $1,800 a month, but that difference doesn't, you know, like Diana was saying, a lot of it can be about providing people with choice, and going from, you know, $1,308 a month to $1,800 a month does not necessarily change those choices that you have to make, and doesn't allow, you know, people who are living with cancer, people with heart disease, other sorts of life-limiting illnesses, it doesn't provide them with the dignity that our society should be striving for. And just, you know, as a basic human principle, we should have as a society the ability to take care of our older adults and our people who are living with disabilities. And so, I mean, I think from my perspective, the other thing that ODSP offers is that you can fill out a medical special necessity form that gets people access to medical supplies for their illnesses. So we're talking about things like insulin pens, insulin needles, wound care supplies, ostomy supplies. And once you switch from ODSP to GIS, OAS, those things aren't covered anymore. And so, you know, even we've kind of legislated this system of poverty to keep people in this, you know, under the poverty line, but also have kind of restricted all of their medical care to this system as well, and all of their home care supplies and things like that. And so I think, you know, when we're able to get somebody from OW to ODSP and we can get them all access to all these medical supplies, we can see how much it changes their care. But when they age out of ODSP to OAS and GIS, then you're looking at things like trying to get people donations from other clients or from other organizations. And there's no reason why, you know, a country like Canada, we should be having to do that and have a system that's set up in place to fail our people as they age. And I think one of the things, working within the shelter system and working with a lot of people who are precariously housed is that this, the group of people that we're seeing are getting older and older and also getting more medically complex. And I think that these, all of these systems, when they were designed, were not designed with this aging population in mind. And I think that going forward in the future, I think we all need to be advocating for, with this in mind, to also provide dignity for older adults who are kind of going through this, not only the hoops of the shelter system like Diana and Bea were mentioning, but the hoops of this income support program as well. And so I think with that perspective, maybe I'll pass it on to my colleague who's co-panelist who's got a video for us.
Thank you again, Dr. Mori, for your excellent presentation that we will come back to in Q&A. So it's my pleasure, as you mentioned, to turn it over to the video of Alexa Ferdinand, who's going to be giving perspectives from Alberta. We've heard a lot from Ontario today, but I'm sure much of what Dr. Mori talked about is applicable in other disability support programs across Canada. And of course, what Diana and Bea talked about too. So Sylvia, I welcome you to please bring up Alexis's video, and a reminder to people who are listening in French that our amazing interpreters will be taking a break during the video, and we'll all be relying on captions if you need them in French, because the audio is not effective when we're playing a video. So we'll be relying on captions if you're listening in French.
Okay, give me one moment, please.
And I'll just mention that Alexis wanted to be here, but couldn't. So if we get any questions for her, we will take them back and hopefully address them at other parts of our summit this week. Thank you, Sylvia.
I'd like to thank the conference organizers for inviting me to present at this summit as part of the Income Insecurity panel. My name is Alexa Ferdinand, and I'm an assistant professor in health and nutrition at Athabasca University. The title of my talk is Examining the Potential of a Tuition Assistance Program to Improve Women's Health Outcomes in a Rural Oil and Gas Town in Alberta. I'd like to acknowledge that the research I'll be sharing in this presentation was conducted on the lands of diverse Indigenous peoples, including Cree, Nakota Sioux, Saulteaux, Dene, Métis, and Inuit peoples, on lands now known as Treaty 6 Territory and Métis Region 4. So today I'll be introducing you to the town of Drayton Valley and their tuition assistance program. I'll describe some challenges that the town has faced in terms of implementing the program. I'll present some initial impacts we've seen on students and wrap up with some conclusions and next steps. So for those of you who may not be familiar, Drayton Valley is a rural oil and gas town of approximately 7,000 people, about a 90-minute drive from Edmonton. It became a town in the 1950s with the discovery of nearby oil reserves. So oil and gas is very much entrenched into Drayton's social fabric. It's typically expected that men will enter the oil field straight from high school and make a pretty high salary, while women will be staying home and taking care of the children. Researchers have referred to the oil and gas industry in Drayton as golden handcuffs because of the associated boom-bust cycles, where there are periods of very lucrative employment, followed by periods of very high unemployment and out-migration. With community-wide income insecurity comes a lot of stress and various health and well-being issues like increased substance use, mental health issues, and gender-based violence. Income instability across the lifespan can lead to prolonged stress within family units. And because the oil and gas industry incentivizes a lack of education, post-secondary education completion rates in Drayton are fairly low, so around 45% compared to the national average of 65%. The most recent oil bust in 2014 hit the town really hard, and they wanted to do something that would both shock-proof the local economy and start to shift the culture of education. So they introduced a program which they called zero-fee tuition. And this was a post-secondary tuition assistance program which would help to revitalize and diversify the local economy. So their goal was to develop a more diverse workforce by reskilling local residents who were looking to train for new careers in different industries. The program provides up to $5,000 in tuition subsidies for residents of Drayton Valley, and it can currently fund about 30 students a year. The first cohort of students in the program began in January 2020, and the town has established partnerships with 4 different post-secondary institutions, a healthcare aid academy, Del Mar College, Northern Lakes College, and the University of Alberta's Faculty of Extension to offer dozens of programs collectively. Students have enrolled in a variety of different programs. These include business admin, early learning and childcare, web development, healthcare aid, just to name a few. So my former postdoc supervisor, Maria Mahan, she had met with the town when they were interested in partnering with the U of A, but she and her research team were really intrigued by the town's innovative approach to rural development. So they submitted a grant to the Future Skills Center, which was successful to then study this program. When we interviewed community stakeholders about what they thought the goal of the zero fee program was, we heard many different things. For example, the program was intended to encourage economic development while also increasing access to education opportunities for all residents in the town. The equity-oriented framing of zero fee, so the idea of making education accessible for all, counters that of traditional economic development approaches, which tend to be focused more purely on economic gains. So this little program has a lot of weight on its shoulders to be considered successful. For those in the town who were concerned with rural revitalization, population retention, and economic development, it was a big ask for a little program to be able to accomplish all of these goals in just a few years. Implementing the program has posed a range of challenges to the town, which I've illustrated a few of them in this diagram here. A municipally funded post-secondary education program is a really bold, potentially risky move for a conservative-leaning town. The oil and gas culture embeds a pull yourself up by your bootstraps mentality. So that is, like, if you want education, you have to figure out how to pay for it by yourself. Some councillors and residents in Drayton don't necessarily think that the program should be funded by taxpayer dollars. Others have also perceived the program, which promotes education, as an attack on the oil and gas industry, rather than as an initiative designed to broaden people's career options. Another challenge is that people expect to see immediate outcomes, when in reality, it could take several years to see broader community-wide impacts. And this is particularly the case given that the COVID-19 pandemic emerged kind of just right around when the program was first starting. So that kind of stalled the program for a bit. To address some of these challenges, the town established an education committee, which was made up of town councillors, high school staff, town administration, all to oversee the running of zero fee. And during committee meetings, members would then be able to hash out some of these challenges. Part of this committee's work involved developing partnerships, including partnerships with post-secondary institutions, community, and the research team. Additionally, there's also been some key champions of zero fee, so outspoken advocates in the community, like high school principals who support it and spread the word to share information about its potential benefits. There are also structural factors which explain why a program like zero fee would arise in the first place. So while tuition assistance programs are relatively rare in Canada, there are hundreds in the United States. And this patchwork of programs, while providing tuition assistance to some people, is a result of lack of funding from higher levels of government, and thus higher tuition rates. Tuition assistance programs are kind of a piecemeal solution, but they may not be the most efficient or accessible forms of tuition support. They can be difficult to navigate and difficult to sustain, and students may not always be aware of what funding they can actually access. As neoliberal reforms increase in Canada, like marketization and performance-based funding, we expect there may be an increase in tuition assistance programs like zero fee. Tuition assistance programs can provide options in rural communities where it's difficult to attract post-secondary education options. So in the case of zero fee, Drayton Valley has formed partnerships with those 4 post-secondary institutions I mentioned earlier, which then allows them to provide dozens of local and online program options for local residents. One key champion in the town is the mayor, Nancy Dodds. She's been a really fierce advocate of promoting education in Drayton. So her quote says, "We're a proud oil and gas community, but we can also be a college community that offers endless opportunities right here in Drayton Valley." So this quote kind of highlights some of the tensions I was mentioning earlier between oil and gas and post-secondary education. Nancy is really skilled at meeting people where they're at, even those who would outright reject the notion of this program. So this was a poster that was put up to advertise the program at a Black Gold Gala fundraiser for the Zero Fee program. And so this gala was held to celebrate the 70th anniversary of the Pembina Cardium oil field discovery. So that in and of itself kind of presents an interesting juxtaposition between oil and gas culture and that of post-secondary education. In addition to program stakeholders, we also tried to talk to as many Zero Fee students as possible to learn about their experiences in the program. We did surveys, interviews, and focus groups with students to answer this question. Nearly all the students we spoke to or who've enrolled in the program have been women as well, and the healthcare aid program has seen the highest numbers of student enrollment. The average age of participants was 34 years old, but there was quite a wide range, so 18 years all the way to like early 60s. Through conversations with students, we heard that the Zero Fee program provided a low risk entry point into post-secondary. For many of them, this was the first post-secondary education or training program that they'd ever enrolled in. For some students, they had previously wanted to enroll in post-secondary, but the cost of it was simply too much of a barrier, and Zero Fee either shrunk or removed that barrier altogether. We also heard how Zero Fee students inspired others in their social networks to pursue education. So some of their friends and family members were encouraged to go back to school, or they had an interest sparked in education by having seen their mom, for instance, finish a program. And this poster is of Toby. She's a healthcare aid student, and this was also posted at that Black Gold Gala. Her quote says, "When I found out about the town's program, that I could better myself, and they were willing to help me, my whole world changed." Some students' income levels rose quite substantially because of their newfound education and training. So for example, one student who previously had been a nanny, she was now able to support herself comfortably with her new office job. Not only was she making more money, but she also felt more confident and secure about her long-term employment prospects because of her education. However, the incomes that I've noted on this slide were somewhat expected. The healthcare aid students in particular, and these, like I mentioned, have been the majority of students in the program. These students showed us that Zero Fee had impacted them in ways that we hadn't necessarily anticipated. So we talked to healthcare aid students in focus groups throughout their program and several months after its completion too. A really big impact was the increased confidence, self-esteem, and sense of belonging the students reported. At one focus group with completed students, I asked them if they stayed in touch with other students from their cohort. And they kind of laughed at me because not only did they stay in touch, but some of them were texting each other multiple times a day and had in fact developed quite close friendships with one another. The healthcare aid students were all women. Many of them were raising families, going to school and working, while their husbands worked in the oil fields out of town. So these shared experiences became bonding opportunities. If they needed last-minute childcare while they were scheduled to work, for instance, they would step in to care for each other's kids. One student described previously wanting to move away from Drayton, but then changed her mind because of the deep friendships and belonging that she now felt in Drayton. It had become her home. The students also talked about having this new sense of confidence in their abilities to learn. Some hadn't had the best high school experiences and previously struggled academically, but by graduating from this program, they were able to prove that they could succeed in post-secondary education. Another key finding was how some of the students began to feel empowered to advocate as union members, contributing to the development of an updated collective bargaining agreement. Relationships then developed between the current and past cohorts of students because of discussions about this new CBA. While some students were interested in the opportunities the healthcare aid program had provided them in terms of stepping stones to other programs like LPNs, the licensed practical nursing or registered nursing programs, others were also just really thrilled to have found a job that they loved as a healthcare aid. It was meaningful to them. They loved working with residents and patients on the ground, and they felt that having their hands-on in-person training gave them skills which many of their coworkers lacked. And finally, the health grade students emphasized that the dire shortages in terms of healthcare aid specifically, but healthcare more broadly in Drayton. They felt that this program had been really helpful for helping this much needed gap in the community. So in conclusion, post-secondary tuition assistance programs are relatively rare in Canada. Municipally driven and funded programs like the zero fee program in Drayton Valley are even more rare. This program has been a pretty unique and innovative way for one rural town to try and spur development and economic activity in the community while directly trying to improve the lives and opportunities for residents. But it's also been very challenging and a divisive initiative in the town. It remains to be seen whether this program will last, given the multiple conflicting views about the roles and responsibilities of a municipality in post-secondary education. We're continuing to pay close attention to the sustainability of the program, which is really attached to buy-in from town council. We're continuing to explore the long-term impacts of zero fee on students and on the community. And we're also considering whether this is something that might be scaled up and adapted for use in other rural communities. And with that, I would just like to say thank you to our research participants and our Town of Drayton Valley partners. The principal investigator for this project is Maria Mann, and I've included both of our contact information via email addresses here. And thank you again for coming to my presentation.
Thank you for playing that, Sylvia, and of course to Alexis, who couldn't be here today, but for her time and presentation. And if you have questions for Alexis, let us know, because it is an interesting example of social policy with leadership being engaged and also in a tense environment where there are different voices that have to be heard and integrated into thinking. So if you have any questions for Alexis, please share them, and we'll do our best to get her to reply and share that back with you. But for now, it's my pleasure again to welcome back Bea, Diana, and Dr. Mori. And I'll start by asking Bea if you're ready and on your, okay, perfect. The first question that came up here, as a strong advocate with current lived experience of houselessness, what do you think that patient groups, so groups like ours and other healthcare stakeholders, need to do to ensure that your voice and the diverse voices of others, you described there are a diverse community of people, of course, affected by this issue. What can we do to help ensure that we're including voices like yours better in our work?
Well, a lot of homeless, they go to emergency room. And well, most of them, if they are like long-term homeless, they kind of like in and out of hospital a lot. And I think, you know, as a patient group, you can advocate to welcome them to have a good experience. I remember when I was homeless and I fell many times on the way to warming center out of court, and I got sent to emergency room. It was like that kind of sense of loss, and because you went there, you got sent into emergency room, or sometimes I walked to emergency room because I didn't go with the ambulance. So I sleep in a subway train, and a few times when the streetcar sudden turn, I fell and hit the seat of the streetcar, and because of the head, so I went to, and I couldn't get to the outer court. It was full, so instead of I went to the emergency room, and so I can have a warm place to be, and also to check my head, make sure it's okay. And so when you go there, there are a lot of people, and nobody really pay attention to you. Mm-hmm. You know, you just like kind of lost. You know, especially when you are in a new hospital, and yeah, so like make people, homeless people feel welcome, and paying attention, you know, to get them adjust and not to be so lost. Right now, the Semite Hospital, they are trying this pilot project called Emergency Department Patient, the homeless, to help them feeling not just welcome, also to help them in like trying to find houses for them, also like attend to their healthcare need, and a lot of things they are doing, and it's a pilot project, and they interview me to about the survey, to ask the patient, the homeless, and it's a good program. I hope you will not just in St. Mike Hospital, but also extend to other hospitals. Because to that program is the they really like care, holistic care about the homeless people who come to emergency department, and not just you come in, we help you to get the doctor see you, but also follow up on the need of the people. So this is a good program.
Excellent. Thank you for sharing that with us. I'll just have you be back on mute so there's no echo. Thank you so much. Thank you, Bea. I think I'm hearing, making the engagement welcoming, ensuring that you're going to where people are, in this case, the emergency room. Diana had also talked about surveying your community, if that's what you're serving, whatever community you're serving. So thank you so much for sharing those insights. The next question we have for Diana: what opportunities do you see to advocate for reforms within the housing and shelter sector? And how can patient groups contribute?
I feel like it's unfortunately much more closed off than I would like it to be. But, as I was saying before my presentation, talking about how we need to give the power back to people who are actually using the services to have some kind of input and control that's meaningful over what those services look like. So, supporting that, I think that kind of mechanism would be really important. But in terms of kind of the intersection of homelessness and patient groups, supportive housing. Advocating for supportive housing, because this is needed not just for people who have experienced long-term and chronic homelessness, because we know that the health outcomes for people will get significantly worse the more that they are within homelessness. But we know also as well for lots of other folks, for different reasons, different health reasons, that supportive housing is something that is vitally needed, but unfortunately quite absent for a lot of folks. So we have this kind of coalescing issue between these two groups. And so I think, it would be mutually beneficial for us to collectively argue, fight for, demand more supportive housing. But also another intersection would be ERs. Because we know that people who are unhoused have a tendency to go to ERs for all of their healthcare needs because they're not connected in other ways. That has negative outcomes on all patients, because we know that essentially we are providing support that could be provided in another space, which is taking, unfortunately, away from other patients who may have emergency needs in the EDs. So I think advocating not just for housing here, but for healthcare access for people. The Ford government did eliminate essentially funding for people who didn't have OHIP coverage. And that actually includes a lot of people who are houseless, who have trouble holding on to their IDs. They get lost all the time. If you have nowhere to store things, it's just a reality of things. And so again, they're going en masse to EDs for their healthcare needs instead of being able to go to a general physician, for example, in part because there are just a lot of barriers there, but also because there isn't funding available. So I think reestablishing that funding would be really important. But I would say, yeah, those are the two intersections that we can kind of work on together, is the supportive housing piece, and then the overcrowding that we see in emergency rooms for lots of different reasons, but also in large part because people don't have anywhere else to go for healthcare needs. So opening up more access for them and eliminating barriers as well.
Fantastic. Thank you so much. And I think our Summit Integrated Healthcare Working Groups is kind of is the place where we might be able to do some more thinking around those different intersecting areas, because it's exactly it. It's like, how are we actually supporting people in the healthcare system when we know that these problems intersect and we could be thinking about them that way. So thank you. Sorry, I will turn it to Dr. Maury. What opportunities do you see to reform social assistance to stop legislating poverty, which I think was a very powerful statement you made? And what roles, again, can this audience, in particular patient groups, play in these efforts?
I mean, I think the simple answer is to give people like a reasonable amount of money to live on. And I think, you know, I think in like putting my like punk rock hat on, I think if you could get whoever the minister is who makes these decisions to try to live on OW for a month, and then, you know, whoever has to make those decisions has to be able to prove to the rest of us that they can manage to do it, I'd be happy, you know, to see that happen. But, you know, I think, you know, not in a non-facetious way, I think a lot of the ways that we do make change, and change that, you know, unfortunately is, you know, there's lots of barriers to getting into the rooms with those people who make those decisions. But kind of like what Bea was saying with the program that started at St. Mike's, and Dr. Wang, who's one of the researchers who runs it, I think part of it is that you get a little bit of funding from either patient groups or from, you know, a research place, and you create a model, like you just go out and you do it on the ground with a little bit of funding from some other group, and prove to them that you can do it better than them, and then bring that project and say, hey, here's what we're doing, we're making it work, this is what people need, and we need to scale it up. And I think Fred and Alyssa are great examples of that at St. Mike's, and they really care for people. And I think it really hurts, actually, because I was just recently with all of them, and I think it hurts them to run this study because they're like, everybody could benefit from us. And then when people, you know, it's a randomized trial, so when people don't get randomized to them, they know care is not going to be as good as somebody else's. But with this all of this bureaucracy, you know, you have to prove to somebody that you know, having somebody help other people makes a big difference in their life. And it's just insane that we have to do that. But that's part of, you know, they form these expert panels, and they kind of make all these people have to do all these things. I mean, Stephen did a study, you know, that's probably like a decade old at this point, where he was giving people living with mental illness rent subsidies, and proving that that would prevent people from going to the emergency department. And, you know, still, after he's done it across the country, he did it like gold standard research methods. You know, it still takes everybody, you know, you know, I have to, you know, in order to convince somebody that even to get a supplement that's less than what Stephen put in his study, you have to fill out like a 10-page form to convince somebody that someone's disabled enough to earn, you know, an income that's below the poverty line. It just is insane. So I think, I mean, all of these stories do add up. And I think that as patient groups, I see this other question here in terms of talking about specific diseases. I think there's no specific disease, but I think that we start to see how much income, you know, instead of being able to have a secure income, a secure place to live, somewhere where, you know, you have a phone where you can talk to doctors, now that we're doing all this virtual care stuff, you know, it's that people who have any sort of disease process, we know that it gets worse because they don't have access to these things. And the reason they don't have access to those things is because our income security programs in this country are like keeping people in poverty. And so, I mean, I think the thing is using your voices as patient groups to advocate and bring those stories forward and say, you know, if this person had this, you know, had a livable wage, had a livable income, had a stable housing situation, this is what their health could look like. And having other people who have access to those things say, this is what my healthcare looks like. This is what my, you know, somebody else's healthcare looks like. Why can't we, you know, provide this for everybody? I think those stories are really powerful, even for legislators who maybe disagree on a political side of all these arguments. But I think when they see the story and they see what actually happens, I think it's really important, like especially having somebody be like you to come up and share your story. I think that's really powerful for lots of people, and getting more people kind of in an audience with those people who actually make those decisions, I think is the most important thing. So yeah, maybe I'll leave it at that.
Thank you so much. And I mean, I can just look at the community I work for, the psoriasis community, and we know that people do worse when they have multiple illnesses, for example, when they are below the they're below poverty line. Like, so I appreciate your perspective and do think that we have to look at these things systemically, of course, right? So the next question, you all in your talks touched to some degree on the aspect of like older adults in these systems. And so maybe I'll start with you, Dr. Murray, briefly, and we can see if Bea and Diana have anything to add. The question is, I suspect that in 5 to 10 years, there will be a boom of homeless seniors. This person is on disability now, but when they did work in frontline services in Ontario, they were seeing homeless seniors in 2010 through 2018 when they stopped working. And they had a client who died by suicide due to their situation. Are there talks anywhere in the government that you're aware of about better support for seniors, in particular with low fixed incomes?
That's just so unfortunate to hear. And I think it's, to be honest, I think I know that there's an idea that there's going to be a boom sometime soon, but the boom is happening. Like, I think there's a lot of people out there who are older. Everybody that I'm seeing in the shelter system, they're all older adults. Are there any specific conversations is a great question. I'm not invited to the conversations. I guess maybe they're behind closed doors or something. I mean, they've always talked about this nutrition, like market food basket measure as like a way to define the poverty line. And I know that at least in this year's report, it showed that the number of people who are below that line as seniors over 65 has almost doubled. So it's just they have the data for it. It's just that, no, I don't know. The fact that anybody has to be below that level for 65 is just crazy. And I think maybe even just to add, Louise, I saw that you put in the chat about cancer patients specifically. I think the interesting thing about cancer patients is that in the shelter system or people who are precariously housed, a lot of those people get diagnosed with cancer earlier, and you can imagine trying to live diagnosed with cancer and try to navigate appointments and your whole life becomes appointments, and you have no time to like even start thinking about filling out all this paperwork to get your essentially double your income. And so unless a doctor brings it up to you, or unless you have a great caseworker or someone who's like, you should talk to your doctor about this, then sometimes those things aren't even like close to the top of your priority list. But I think a lot of the people, cancer is something that has touched almost everybody's family. And I think it's something that also comes with a powerful story for lots of people who are decision makers or not. And I think one thing about healthcare is that it's kind of like a level playing field. Like, it's not like, thankfully in Canada, if you have a health card, then, unfortunately, like Diana was mentioning, they kind of cut the uninsured services for people. But if you have an OHIP card, doesn't matter what your income is, you go to the emergency department, you'll get seen by a doctor. I think if you walk through the ward of a hospital at any time, you're going to see all sorts of people on the income spectrum, and no amount of money is going to change, those health outcomes for you, other than getting diagnosed earlier, having the education, having all of the prevention in place to prevent those things from happening earlier and from those things getting worse. So I think, in terms of aging, I think the other thing to think about is that people, living in poverty and who are experiencing homelessness, their age on paper might be 65, but from a medical perspective, a lot of the time, you're seeing somebody who's 65 and they're presenting like they're 80 years old, like with all of the health complexities of an 80-year-old. And so I think that sometimes, you think, with ODSP, you can apply for all of these different, but a lot of the time, as they age out of that system, you lose all of those things. And I think that, we need to rethink a system that was designed for younger, healthier people and focus on what actually exists kind of today.
Thank you so much. And we heard some of that earlier too. I'm going to do a quick rapid fire to Bea and Diana, just because we are running out of time, but I want to hear their last words on anything specifically around the older adults question, if you'd like.
Well, government have this Canada Disability Benefit. It had passed, I think, the third hearing and even get okay from the Senate, but it's not fully become law. So I think at Advocate we can really push for that benefit to come through. That will help a lot of people, especially those people who are with cancer, to have live a dignity life at their old age. So that's what I know about the Canada Disability Benefit. Thank you.
Thank you so much, Bea. And yes, I encourage people who haven't read up on the Canada Disability Benefit to read about it, because it's they're developing regulations now, so it's really an important opportunity for our communities. And Diana, I'll turn it to you for the last word on your experiences and any perspectives you want to share. The last question.
I mean, I think Dr. Morey put it perfectly. It's like we are already seeing this huge increase in people, and certainly in the work that I'm doing, I'm seeing more and more seniors who are now on the streets in pretty dire situations. I also want to reflect on the fact that Dr. Morey is talking about the fact that people present older than they really are. And so when we're talking about seniors, the age that we might attribute to officially someone being a senior doesn't really mean a whole lot in terms of physically what's going on for somebody. Someone could be in their late 40s and certainly present with a lot of the same challenges in terms of their health as someone who is significantly older. So those categories in our work become a little bit more fluid and in some cases a bit meaningless because the challenges are just so great for people. I would say, there isn't a lot of discussion about this at the policy level, certainly at any level of government. There are certain facilities that are for seniors housing as well as shelters. There is a senior shelter, at least in the city of Toronto, which is consistently full, in which we can't get people into it regardless because they are not moving out of that shelter. So it is effectively housing for those people without the ability for new people to actually access those services. So, I'm thinking about one fellow in particular that I've been working with for the past year, and he's good now. I'm very pleased. He's actually in really good space. When he arrived in Toronto, he was living on the TTC and, had nowhere essentially to go and couldn't find any kind of shelter access and just physically and emotionally was not doing very well. But he had a fairly decent amount of money versus people who are on OW or ODSP. But the issue there was that he actually had too much for RGI housing, which is to say he had $3,000 in savings. It's nothing. It's nothing. They want you to bottom out everything that you have available to you in terms of your resources before they'll actually give you anything. And what I actually had to do, because we put in a housing application that's successful, he had a second bank account and we withdrew all that money in cash and put it in a safe. That's what we had to do in order to make sure that this fellow could actually have access to housing, which he wouldn't have been able to afford market rent anyway. So he was in this kind of bizarre location where he wasn't eligible for low income supports because he just wasn't low income enough, but not able to access market rent, anything on the market. So these are the kinds of things that we have to do sometimes to bend the system to actually make any kind of sense. But it's really contingent on like individual workers and someone being fairly savvy in order to navigate that. And obviously as well, if it was to be found out, so I'm not using names here, he could lose his housing, which is absurd. Because again, it is not actually a lot of money. So I do want to reflect on how these systems are strangely barriered, not just really high barrier, but strangely barriered to disallow access to certain services for people. And it's something to keep in mind as well. If we're looking at homeless seniors in particular, is that the amount of money they may actually preclude that they're not eligible for a lot of supports, which contributes actually to people being on the street and in shelters because they're just in this limbo. So something to keep in mind and something that's truly moronic, if I can use that word. case.
You can. And it's your presentation. But I think you've done a great job of giving examples of that idea of we've legislated poverty. Like, what do we mean? And you've given us really concrete examples of how we're making people who already have to work so hard to remain homeless work even harder. So thank you. And so I just, before we wrap this up and turn to our breakout rooms, if you all have a minute longer, this might just be for Dr. Mori to pick up on the comment Louise made about the Canadian Cancer Society. I think that's what CCS means. The 5 areas that they cover are being underrepresented: older age, newcomers, racialized communities, rural and remote communities, and Indigenous populations. The report makes 5 populations. Oh, she's already writing to them. The question has been answered. Should we talk to them and make recommendations to CCS for these specific populations?
Amazing. Great work, Louise. Okay. Keep it up.
Okay, great. Thank you so much for this insightful, inspiring, and motivating panel. In particular, thank you for sharing your lived experiences with us today. It's not easy, I'm sure, and I just want to acknowledge that we appreciate your willingness to share with us your experiences. So thank you so much. And we hope to work with you again. And you're welcome to stay for the rest of the summit over the next few days. Thank you.
Thank you so much, Antonella. So now we will be moving into our final round of breakouts for the day. Please do stay. We really want to hear your reflections on what you're learning so far, what you think the implications of what you're learning might be on your patient community or your sector, if you're from another healthcare stakeholder group. So just give us a moment as everyone gets transferred over to their breakouts, and really look forward to hearing the themes of what come out of your conversations. And we'll see you all on Wednesday. Don't miss it. Indigenous health, meeting the needs and understanding the issues in Indigenous health will be touching on some really important topics and hearing from incredible speakers on Wednesday. So please do join us then. And until then, enjoy your breakout conversations, and we'll see you Wednesday.